Zoom पे है. They would have sent you a faculty link because there are two links. No, one is an attendee link. You would have received your mail pay faculty link, or I'll forward it immediately. Yeah. Yeah. Sure.
Yes, Ashish sir.
Yeah. विवेक राधाकृष्णन सर को लिंक भेजा है क्या? मतलब he was called up.
डॉक्टर सो आराम
उनका फोन आया था.
हाँ, ये डॉक्टर विवेक को जरा वो लिंक भेजने का है, तो एक बार मेल या तो फॉरवर्ड कर दो या व्हाट्सएप कर दो, मुझे कर दो, मैं फॉरवर्ड करता हूँ, या आशीष सर को कर दो.
मैं सर को भेज देता हूँ.
यहाँ पे है मुझे मैसेज. I'll forward him.
हेलो आशय.
हेलो सर.
10 मिनट भेजना चालू करेगा.
काय म्हणते सर?
हाँ बस ठीक आहे. तू कसा आहेस?
आज बस ठीक आहे. आज गेला होता TMH की काय?
नाही आज नव्हतो गेलो मी. तू डन विथ ओपीडी?
नाही आज ओपीडी नसते. मी डे 1 पासून सॅटर्डेला काम नाही करत.
आय थिंक दॅट मच नीडेड रिस्पाइट.
नाही सर, बट डे 1 पासून म्हणजे माझ्या सगळ्या पेशंटला सवय आहे, ते सॅटर्डेला येतच नाही. मी बसलो तरी येत नाहीत. कारण युजली आपल्या मीटिंग्स काय ना काहीतरी असतंच, आणि एक दिवस तरी पाहिजे सर. काय
अशा आय थिंक चांगली प्लॅनिंग केली आहेस, बट विल कीप टू द शेड्यूल. वी ट्राय अँड फिनिश ऑन टाइम.
फक्त ना थोडा एक प्रॉब्लेम आहे. वामशीचा पॅरलल सेशन आहे. तो म्हणाला, तो आधी पण एका ठिकाणी कुठेतरी मॉडरेटर आहे, तो म्हणाला मग एक 5 मिनिटं, म्हणजे त्याचा 7:25 आहे ना, तो म्हणाला मी 7:30 पर्यंत. म्हणजे ठीक आहे, तेवढं तर होईल म्हणतं. पण आधीचं जे आहे ते फार्मा स्पॉन्सर्ड सेशन आहे ना, ते थोडंसं हे होईलच. पण एनिवे आपण वी विल जस्ट फिनिश बाय 8:30 सर. म्हणजे किती हे झालं तरी म्हणजे
या वी कीप इन टाइम. आणि सेकंड थिंग इज नो, माझे पॅनलिस्ट ना, मी त्यांचे फोटोज वगैरे टाकलेत याच्यामध्ये. आय विल इंट्रोड्यूस देम. चालेल?
हो सर, तुम्हीच इंट्रोड्यूस करा. येस सर. मी हँडओव्हर फक्त म्हणजे मॉडरेटरना हँडओव्हर करून हे मॉडरेटरच इंट्रोड्यूस करतील सर. येस सर.
मी ती गाईडलाईन बघितली नव्हती, पण मी गाईडलाईन बघितली.
नाही सर, त्याचा काही इश्यू नाही सर. हे आपण काय कर, म्हणजे मी तर फक्त जस्ट सेशन कोऑर्डिनेटर म्हणून करणार आहे. सो बेसिकली मॉडरेटर्सने आपल्या पॅनल्सना इंट्रोड्यूस करायचं आणि हे करायचं सर.
तुला
काय म्हणते सर?
तुला प्रोएक्टिव्ह राहून थोडी टाइम मॅनेजमेंट करावी लागेल, अदरवाइज ना.
नाही सर, ते आपण करूच ना. तर बेसिकली हे करू. मोस्टली आपल्याला ते 2 पॅनल्स आहेत तिकडे थोडंफार करता येईल हे, म्हणजे तसं काही इश्यू येणार नाही मला वाटत नाही. पण आय थिंक वी शुड बी एबल टू फिनिश ऑन टाइम. फक्त आता हे सुरुवातीचं सेशनच हे आहे ना, कारण ते हे फार्मा स्पॉन्सर सेशन आहे ना, तर ते फक्त आपल्याला थोडं बघावं लागेल, बाकी काही नाही. कारण त्यांचं जे पॅनल आहे ते वगैरे ते त्यांचं आहे ना, ॲक्युलर बरोबर. पण सध्या वापरतो का आपण, म्हणजे अजून आलंय का, म्हणजे तुम्ही वापरलं का हे इकडे एकायला?
नाही आणखी आय थिंक लॉन्च झाली नाही वाटतं ना.
नाही म्हणजे मला तरी आठवत नाही, म्हणजे कोणी आलं तरी नाही माझ्या ॲस्ट्रामधून हे करायला. इब्रुटिनिब तर वापरतो जॅन्सनचं. हा, आणि इब्रुटिनिबचं तर जेनरिक्स पण ऑफिशियली आलेत ऍक्च्युली, आय थिंक सो. विचार पुढे शिल्पा लाईफ सायन्सेस आणि अजून 1-2 जण आलेत सर इब्रुटिनिबचे.
आय थिंक फर्स्ट मेनन सरांचा टॉक राहील, सो दॅट इज.
हो, मेनन सरांचा आहे पहिला टॉक.
पॅनल डिस्कशन दीपंजन, प्रीती अँड राजेश.
या ते झाल्यानंतर मग आपण हे करू सर.
चालेल.
म्हणून तेच. बाकी काय म्हणता आणखी सर?
बाकी मजेत.
मग आता तुम्ही हल्ली असं हे नाही ना, म्हणजे अट्रॅक्टला हे वगैरे असं नाहीच आहे ना, तसं ते काय म्हणते हिमॅट काय
करेल ना.
काय कोविड सिच्युएशन काय सर? माझे तर भरपूर पेशंट कोविड पॉझिटिव्ह यायला लागले.
आय थिंक मध्यंतरी थोडे कमी झाले होते, पण अगेन आता वाढायला लागले.
आज एकाच दिवशी 4 पेशंट आलेत म्हणजे कोविड पॉझिटिव्ह आलेत. एक हे आणि मेलॅनोमा एक्सलंट रिस्पॉन्स ऑन निवोलुमॅब. 18 सायकल झाल्या, CR मध्ये गेला, आणि आता ह्याच्यावरती 20वर गेलाय कोविड पॉझिटिव्ह. पूर्ण CR मध्ये गेला, सगळं झालं. मी त्याला म्हटलं तर वन्स अ मंथच घे म्हटलं, तू घेऊ नकोस म्हटलं. ॲज एक्सलंट रिस्पॉन्स, डॉक्टरच होता. एज 56. त्यामुळे एक CA प्रोसिजर आहे, तो तरी ठीक आहे, 80 इयर्सचा होता. मी तो बिनाईन हिमॅट पण बघतो, एक अप्लास्टिक अनिमिया होता, तरी मी त्याला ATG चालू नव्हतं केलं. मी सायक्लोस्पोरिन आणि हे आजकाल चालू करतात ना, तर ते चालू करून ठेवलं होतं. ही हॅड हे परवा. सो असे 3-4 पेशंट आजच्या एकाच दिवसात. एक मेटास्टॅटिक CA ब्रेस्ट होती, तिला TDM1 प्लॅन केलं, म्हणजे कार्डिओलॉजिस्टची आईच होती इकडच्या. आणि she presented today as a COVID. ठीक आहे.
So Ashish sir, the request is we will start sharp by 6. I think Dr. Hari Menon sir is joining,
Yeah.
and we'll
Yeah,
start.
sir is already there. Sir is already there.
Sir is already there. Yes, sir. Yes, sir.
Yeah, sir is in the, I think he's in his cabin.
Yeah, I am. Thanks. Hi, Akshay.
Hello, sir. Nice to see you.
Yeah, yeah.
Good evening, sir.
Hi.
Good evening, Hari sir.
Hi. I was still preparing my slides 5 minutes ago. Yeah. So I'll just 1 minute. Let me just prepare my slides and keep it ready.
Yes.
Yeah, sure. Go ahead.
It's 6 o'clock.
Yeah.
Tarun,
I'm ready whenever you are. Yeah.
yeah, surely, sir. तरुण जी, डॉक्टर विवेक को लिंक मिल गया क्या? डॉक्टर विवेक हैज ये उनको लिंक नहीं मिला था. Yes, check it out now.
So Ashish sir, Dr. Vivek sir has joined. So
Okay.
I think
Good evening,
we are
everybody.
good to go.
We can just start.
Yes, sir.
Yeah. So yeah, good evening, everybody. I mean, welcome to this lymphoma update. So basically, September is known for Lymphoma Awareness Month, and so this is a conference which is held. Lymphoma is a very wide subject. I mean, really cannot encompass even maybe in a day or 2 days conference. So what we will just be discussing the controversies, and we are blessed to have a very esteemed faculty with us. And the first to introduce is Dr. Harimenan sir. Definitely, sir doesn't require any introduction. He's a very well-known person across. Sir is a professor in was professor in medical oncology, and fortunate to have him as my teacher, my mentor, my guide. So, sir will currently he's with Site Care Hospital in Bangalore. So, welcome Dr. Harimenan sir, and sir will be speaking about role of ecallantide second generation BTKI in the management of CLL. Over to Dr. Harimenan sir.
Thank you, Ashay, for the kind introduction. I have been given 10 minutes, and I'll just try to do justice to while I would have liked to go through the various phases of how acalabrutinib came into the management of CLL, I don't think that the 10 minutes will permit me to do that. So I will just rush through the topic as such. So let us go into what is the role of acalabrutinib in the management of chronic lymphatic leukemia. Before doing that, let us understand that chronic lymphatic leukemia is a very well-defined neoplasm with very heterogeneous biological and clinical behavior. We do understand what actually allows for the pathogenesis of the disease is a numerous genetic susceptibility that may be even be there. We do see a propensity for CLL in families. And there's immunogenic factors also driving the disease, and several genomic alterations, epigenetic mechanisms, epigenetic reprogramming, modeling of the tumor cells, and microenvironment interactions, which is a very important aspect, and also clonal evolution from a monoclonal B lymphocytosis to
Dr. Hari sir, I'm sorry to interrupt, but we can't see your slides. The screen is blank.
Oh, sorry.
Now it is visible, sir. Make it full screen, sir.
Yeah. Is it there? Sorry.
Fantastic. Now your voice is clear. This is clear.
Yes, sir.
Yeah,
Yes.
thanks. Yeah, so I'm sorry about that. So we do have that clonal evolution of several early steps from monoclonal B lymphocytosis to progression and transformation, and also the Richter's transformation, which is quite akin to diffuse large B-cell lymphoma. So first, let us get into the tumor microenvironment, and we do understand that there are a lot of interactions between the neoplastic cell, the B cell, and the T regulatory cells and the nurse cells, including the stromal cells, which includes the mesenchymal stem cells and the follicular dendritic cells, and also the nurse cells. And all of these contribute to a survival mechanism for the B lymphocyte. They also allow for homing of the lymphocytes and migration into lymph nodes, and also into other organs. And also we do understand the mechanism of drug resistance, which is produced by the in these interactions. But also we know that there are a lot of mutations that have occur in the gene pathways for chronic lymphatic leukemia. And these are a spectrum of all those. We do understand the NOT signaling pathway, which is pretty well understood, and also contributes significantly to drug resistance. And the new theme, and I would not say new theme, last more than a decade, of the BCR toll-like receptor signaling pathways, which we have garnered for therapeutic benefit in terms of perturbing these pathways. You have the MAP kinase pathways, the NFK-kappa-B signaling pathways, chromatic modifiers, cell cycle abnormalities, also the DNA damage mechanism, including the TP53, which we all know carries a poor prognosis in these patients, and also RNA splicing mechanism, particular emphasis of the SF3B1, which actually, the presence of which actually contributes to some sort of a resistance to monoclonal antibodies. But the topic of discussion today would be the BCR and toll-like receptor signaling. Why is it so important? Because the BCR signaling is integral to the proliferation and survival of B lymphocytes. There are downstream protein kinases as called the Bruton tyrosine kinase, which are critical in BCR signaling. And there are a lot of inactivating mutations that occur in the BTK gene, which results what we understand as the X-linked A-gamma globulinemia. And the patients with this particular syndrome have a significant reduction in B cells. And this highlights the importance of BTK in normal B cell development. How does it influence the how does the BCR signaling influence the pathogenesis of the disease? So we do understand that there are several events downstream of the BCR radial signaling, which includes antigen engagement, then the formation of what we call as microsignalosome, which activates almost 4 families of non-receptor tyrosine kinases, which act as transducers actually, which has 4 different pathways, which is including the phospholipase C delta, and also the MAP kinase pathways and the NFK-kappa-B pathway, and activation of serine threonine kinase, what we call as the AKT pathway. In addition, these BTKs, that is a Bruton tyrosine kinase, mediate signaling events which are regulated by various phosphatases that are recruited onto the cell membrane following cross-linking of inhibitory receptors, and exclusively which are expressed on the B lymphocyte. So the BTK activity is crucial for survival and proliferation of leukemic B cells, and for their interaction with the cells in the tumor microenvironment. So traditionally, we know that chemotherapy has been one of the modalities that we have relied upon for bringing some sort of a transient responses to CLL, and we do understand that there are a subset of CLLs which do respond very well to chemoimmunotherapy, and that today we know are those who are IGHV mutated and who do not harbor any of the TP53 mutation or deletions. So, and also we understand if you have a 32 abnormality, those are the patients who are likely to be long-term survivors and have a functional cure in a good proportion of patients, but we do understand this is only a small subset of patients. But definitely chemoimmunotherapy is a modality that is useful for a subset of patients. But what about the utility of BTK inhibitions? Does it encompass all the types of CLLs? Well, I said I don't have enough time to go into the phase 2 studies, but the Resonate 2 study, which was built on the backbone of several phase 1 and phase 2 studies of ibrutinib targeting the BTK inhibitor. We know that ibrutinib is the irreversible inhibitor of BTK, but it has got off-target activities too. But when we look at the outcomes for this patient, for patients who are treated with ibrutinib, the benefits are all encompassing, and we do understand that irrespective of what is the mutation status, and also irrespective of the 17p deletion, they do tend to have excellent outcomes, except that you need to continue with the therapy indefinitely. The E1912 updated progression survival, which looked at comparing ibrutinib with rituximab and FCR regimen, again showed a benefit for the use of ibrutinib in patients across all spectrums. Then we do have the Illuminate study, which looked at the newer anti-CD20 antibody, which is obinutuzumab, and again, ibrutinib scored over the chemotherapeutic order. So clearly, there was a role for the use of BTK inhibitors in treating CLL patients across all risk groups. Then, but the problem with that, with ibrutinib, was it did have some unique problems, and it had off-target activities too, resulting in a significant proportion of patients not being able to continue with the treatment due to toxicities, which includes hypertension, abnormal bleeding manifestations, and also cardiac arrhythmias in the form of atrial fibrillation. And we must remember that we are dealing with, most of the time, with significantly older population. So what does acalabrutinib have to do, and what does it score over in terms of over ibrutinib? Primarily, acalabrutinib was designed as a novel, irreversible second-generation BTK inhibitor, which was designed to be more potent and selective than ibrutinib. It was designed as a selective BTK inhibitor, and the goal was for achieving similar therapeutic outcomes in patients with CLL without off-target effects on other kinases such as the TEC.
Ministry, your slides are not moving. Hello.
So several preclinical studies have demonstrated the efficacy of acalabrutinib inhibition of BTK is similar to that of ibrutinib, and I'll allude to some of them. The ACECL001 study, which was the first phase 1/2 study for frontline acalabrutinib in chronic lymphatic leukemia, and this was based on the background of the activity of acalabrutinib in relapsed refractory CLL in phase 1, phase 2 study, which demonstrated an overall response rate of almost 93%. So what did the ACECL001 study, the updated analysis, have to say? It shows patients who were treatment naive with CLL, and as per the IUW-CLL criteria, who had performance status less than 2, and they compared two dosing patterns in the expansion phase, which started.
So sorry to interrupt you. Hello, sir. Sorry to interrupt. Your slides are not moving. Hello.
Yeah, it's not moving.
Yeah, because we're still stuck up with the microenvironment slide. Yeah.
Yeah.
I'm sorry to bother.
Please click on the slide and then change, sir.
Click on the slide.
Now is it moving? Is it there?
No, it's not moving. Either stop share and share it again, sir.
Pardon?
Stop sharing and again share it again. So,
okay. Oh, so sorry. Yeah.
Yeah.
Just make it
now still go to the slides, sir, and again start sharing.
Yeah. Sorry, is it coming? Sorry. Is it coming now? Has it come?
Yes, sir. The slides are visible right now. Yeah.
Yeah. So now is it moving?
Moving. Yes, sir. Moving.
Yes, sir, it's perfect.
Yeah. Okay. Oh, you should have told me a little while ago. I thought everything was in order. Yeah.
Yeah.
Okay. So we do have the phase 1 study, which was on the background of relapsed refractory CLL patients, wherein acalabrutinib had shown overall response rate of 93%. And this study was basically in treatment naive patient, which looked at two dosing arms of acalabrutinib at 100 milligrams and 200 milligrams, and the treatment is continued until treatment progression. What came about in terms of, as is true for any phase 1-2 study, is to look at what were the adverse events, because that was one of the primary objectives of designing acalabrutinib to overcome the side effects profile that was sometimes unacceptable with ibrutinib. So when we look at the adverse event profile in this phase 1, phase 2 study, they did have a proportion of patients having diarrhea, headache, upper respiratory tract infections and contusions because of platelet dysfunction, arthralgia, petechiae, and ecchymosis. But what one should appreciate over here is that most of them were less than 1 year, and they were self-limiting, and many of them did not tend to persist as we went down the treatment line for the patients. So thereby saying that nothing was sustained, though there were initial side effects that were encountered with the use of the drug, and headache was one of the most common side effects that one encountered. So the conclusions of the ACE-CLL-001 study was that in treatment naive CLL patients, there was no new safety signals that was noted. Most adverse events were grade 1, 2, and the grade 3, 4 atrial fibrillation bleeding manifestations were extremely infrequent in these patients. And overall response rate was as high as 97% and almost 100% in high-risk patients. And the responses appeared durable, with both median duration of response, progression-free survival not being reached at a median follow-up of 42 months. So then came the use of so given the promise of its use in both relapsed refractory CLL and also the phase 1, phase 2 study data, phase 1-2 data. So it was used as a monotherapy for treatment naive CLL, and this was the Elevate treatment naive, the Elevate TN study. TN stands for treatment naive CLL patients, where acalabrutinib with or without obinutuzumab, which was a newer CD20 antibody that one looked at, versus chlorambucil and obinutuzumab for treating naive chronic lymphatic leukemia patients. And in a nutshell, what we can see over here is, as like the ibrutinib data, there was a significant benefit for the use of acalabrutinib over the standard obinutuzumab with chlorambucil. That was the control arm. So, and also noted was that, again, even though there was a marginal benefit for the use of acalabrutinib with obinutuzumab, even the single agent acalabrutinib resulted in extremely excellent long-term outcomes of almost 87%, vis-a-vis about 93% with the combination arm with acalabrutinib. So the 2-year progression-free survival also was significant in the high-risk groups, especially those whether you consider deletion 17p or TP53 mutation, or the 11q abnormality, or the unmutated IGHV mutation, all above 88%, as we see in these graphs. So again, the story of good BTK inhibitions improving outcomes across all risk groups was sustained with the use of acalabrutinib minus the side effects that were encountered with long-term use of ibrutinib. So again, acalabrutinib as monotherapy for relapsed refractory CLL was another important study, which was the ASCENT study, and the final progression-free survival by investigator assessment was published more recently, sometime in June 2020, which looked at the an open label phase 3 study wherein they looked at acalabrutinib, and they had the comparator arm, which included idelalisib and rituximab or bendamustine rituximab. And again, as you will see in the graph, there was a significant benefit for the use of acalabrutinib as a single agent in relapsed refractory chronic lymphatic leukemia. And you will appreciate the median progression survival was not reached in this patient, thereby saying, thereby demonstrating its excellent utility in patients with even relapsed refractory CLL. So irrespective of the TP53 mutation, irrespective of the IGHV mutation, they scored over the standard arm. And if you will, you can appreciate that atrial fibrillation was seen in less than 6% of the patients, hypertension less than 5%, and there was no increased incidence of any second primary malignancy or tumor lysis. So we go to the next step. When you look at the pooled safety analysis, the adverse events in the pooled safety analysis from 9 clinical trials so far of acalabrutinib in B-cell malignancies, a total of 1,040 patients, demonstrates that at a median follow-up of about 26.4 months and a median duration of acalabrutinib exposure of about 24 months, there is 65% of the patients who are still continuing acalabrutinib, 9% only discontinued due to adverse events. And the most frequent adverse events was, as I said, headache, and followed by diarrhea. And grade 3 adverse events occurred in about 54% of the patients, and mostly were associated with anemia and neutropenia, and pneumonia was in about 5% of the patients. Now, can we combine acalabrutinib with the newer agents? We know that venetoclax induces better measurable residual disease, and it has demonstrated excellent activity in relapsed refractory disease as demonstrated by the Murano study. And acalabrutinib was also used in combination with venetoclax and obinutuzumab, and this was in untreated CLL. And this was a fairly elaborate study wherein all drugs were not put into the regimen, and we look at it was put in a phased manner, and the frontline combination therapy, there was, if you will appreciate that the side effects were, though they were present, but they were not very significant. The grade 3 side effects were few in the form of neutropenia, anemia, and thrombocytopenia. Fatigue was a significant non-hematological toxicity that was encountered in this combination regimen. But more importantly, we do understand the utility of measurable residual disease being achieved, and as was true with other studies where venetoclax was being used, the combination of venetoclax with acalabrutinib did demonstrate both in the bone marrow and peripheral blood, with the progressive use of the medication by cycle 15, almost 87% of the patient had achieved an unrecordable measurable residual disease. So there was no significant difference in response rate or between the IGHV group either, thereby saying that it sort of negated all the negative prognostic factors in CLL in this combination. So that is something that we have to look in for the future, and as we see, even as far as the TP53 mutation was concerned, there was a significant achievement of undetectable measurable residual disease by cycle 8 of this combination therapy. So in conclusion, I would say that the final results of the phase 3 ASCEND study confirm previous interim results and demonstrate statistically significant progression-free survival improvements and favorable safety with acalabrutinib versus any of the other regimens. And we know that currently, most of the time, we do use chemoimmunotherapy, and this was one of the control arm. Acalabrutinib benefit conserved across all subgroups regardless of the TP53 deletion 17p or the IGHV mutation status. And long-term safety and efficacy results from phase 2, the ACECL001 study, confirms that acalabrutinib monotherapy leads to durable responses, and there are no real new safety signals in patients with treatment-naive CLL. And together with the pooled safety analysis of acalabrutinib in B-cell malignancies, these reports support favorable tolerability and efficacy of acalabrutinib for patients with B-cell malignancy. So with that, I will conclude and be happy to answer any questions if there are. Thank you.
Thank you, sir, for your pearls of wisdom. As always, elaborative. So there is one question for you, sir, from Mr. Parag Majan. Looking at the data, would you use acalabrutinib as single agent or combination in TNCLL?
So if you look at the data, the combination arm did not have a significant, as is true with the other studies with ibrutinib, the combination arm did not have any significant improvement over the use of single agent acalabrutinib. But there is some suggestion from studies that in terms of achieving a better measurable residual disease, maybe obinutuzumab will have an impact over there, but that remains to be seen. But if you look at the graphs, the difference was between 87 to 93%. So one may be justified in using it as a single agent also in these situations.
Ashik, can I ask a quick question to sir?
Yeah, sir. Go ahead. Yeah.
Sir, excellent talk. We got all the points we needed. But sir, are you worried about this combination of triple drugs like TKI with obinutuzumab and venetoclax? The grade 3,
Yes.
grade 4 hematological toxicities are crossing 30, 35 or 40% in some of the studies.
Yes. So, but the only thing about is that the goal of achieving a measurable residual disease is significantly better, and most of the studies have demonstrated that reaching that target allows for some sort of a functional cure in the future. But you are right in saying that we cannot actually, for a relatively indolent disease like CLL, in most of the situations, for us to chase something like that with a huge number of toxicity that follows with it is probably not acceptable for most situations. But there is a way of also sequencing these drugs in a particular way so that you might be able to reduce the toxicities. So that's how the study was designed. We have to see how many patients can actually, I mean, the long-term outcomes are yet to be this thing, but the primary endpoints of achieving the measurable residual disease, undetected unmeasured disease was achieved. But you are right, always combination leads to much higher side effects, which we saw in the graphs that I showed in my slides. Yes.
Okay.
Thank you, sir.
Thank you, sir. Thank you very much for wonderful explanation. Definitely, sometimes when we read really we cannot get this kind of explanation, which is almost seems very easy when you're telling us.
Oh no, it's not easy. There's so many combinations.
That's the reason why I'm saying it's so many. That's why I'm saying if you're reading it, it is too complicated. But at least so always remember the minimum
Thank
size,
you.
Ashay.
Thank you
very much.
Thank you for having me on this nice program. Thank you.
Yeah, sure. So now I invite Dr. S.P. Verma. He's a consultant hematologist from Lucknow. Over to Dr. S.P. Verma for a panel on acalabrutinib. Yeah, please, over to Dr. S.P. Verma. Please invite your panelists and introduce them.
Hello, good evening, everyone. So today we are going to have a case for panel discussion on CLL. And for that, I would like to invite my panelists. So the first panelist is Dr. Dipanjan Haldar. Is he there?
Yeah, Dr. Dipanjan,
yeah,
he's panelists, unmute yourself. Yeah.
Hi, I'm here.
Yeah, hi, Dr. Dipanjan.
So he's a clinical hematologist and he's consultant at Jupiter Hospital, Mumbai. Welcome, Dr. Dipanjan. Second panelist is Dr. Preeti Jayaraman.
Hello.
She is again clinical hematologist, associate consultant, Max Super Specialty Hospital, Delhi. And the third panelist is Dr. Rajesh Patil. He is a TM hematology and BMT physician, CTC BMT Center, Borivali, and consultant hemato-oncology, MGM Hospital, Mumbai. So Dr. Rajesh is there?
Yes, I'm here.
So I'll share the screen. The screen is visible to everyone?
Yes.
Yeah. Okay. So our panelists are young. I have already introduced all of them, but our case is very old. So this is Mr. MSN, 79-year-old male who has no comorbidities. His performance status is 2. He is diagnosed to have high counts outside on routine CBC, and this was basically he was investigated for the tiredness in June 2018. He had no fever, weight loss, or bleeding, but there was significant tiredness, and he had pallor and no organomegaly or lymphadenopathy. When we did the CBC, his hemoglobin was 9.7. So he was having anemia with a TLC of 39,800 and platelet of 1.79 lakhs. And his peripheral blood picture showed 80% mature looking lymphocytes with plenty of smudge cells and 5% pro-lymphocytes. So we thought of CLPD, or possibility of CLL was there. And flow cytometry was done. We showed CD5 positive, 23 positive, 20 weak positive, 200 positive, FMC7 negative. So it was the diagnosis of chronic lymphocytic leukemia was made. So my first question is to Dr. Rajesh. What are the initial clinically relevant investigations which should be done in this patient at baseline, or any patient of CLL at baseline?
So initial baseline investigation, as we have already in CBC, as there is hemoglobin is low, we'll definitely look for the retic count and the direct cum test, peripheral smear examination, and along with other biochemistry, which includes renal function test, uric acid, liver function test, and generally a triple H, HIV, hepatitis B, hepatitis C. These are the common tests what we do baseline in any CLL diagnosis.
And anything regarding the bone marrow and cytogenetics?
Yes. So if the patient is not requiring treatment, so we generally don't do cytogenetics at baseline. We just observe. And if the patient bone marrow, we do only if there is a cytopenia present. Otherwise, bone marrow is not done. And if the patient is requiring treatment, then we generally do the FISH for CLL and TP53 mutation by sequencing. Yeah, this test we generally do.
So you do TP53 and IGVHG mutation routinely for all patients who are needing treatment?
IGHV I don't do. A TP53 mutation I do generally by sequencing, and FISH for CLL.
Okay. Okay. Thank you. So for this patient, because he had anemia at baseline, we did Coombs test, which was direct test was negative. LDH was within normal limits. His chest X-ray was normal. Viral serologies, including hepatitis B, C, and HIV, was negative. CLL FISH panel was done, but it was no abnormality was detected. Bone marrow aspiration, biopsy, and cytogenetics, otherwise routine karyotyping was not done. And TP53 mutation and IGVHG status was also not done. But as we had Coombs negative and the patient is having anemia, so chronic lymphocytic leukemia, RISE stage 3 or modified RISE stage, modified RISE high risk disease was diagnosed in this patient. So the second question is to Dr. Preeti. As this patient is having anemia, in your clinical practice, what is the incidence of autoimmune hemolytic anemia and autoimmune thrombocytopenia in your practice, in your patients?
So autoimmune hemolytic anemia generally occurs between 5 to 10% of the patients with CLL, and autoimmune thrombocytopenia occurs at even less compared to AIHA, around 5%. So we differentiated based upon the rapidity by which the blood, the hemoglobin is falling, and in case of any very severe thrombocytopenia, which is refractory to platelet transfusion, we can think of autoimmune thrombocytopenia in that instance. Yeah.
Okay. So you are correct. So if you see the data from Mayo Clinic, this is old data, but includes 1,750 patients of CLL and seen over 10 years. You can see that most common cause of cytopenia is bone marrow failure, we all know. But autoimmune disease also constitutes a good percentage of patients, almost 18% in this series. And non-CLL related disorders are also there responsible in almost 10% of patients. And that is why when the cytopenias are not explained, basically we go for a bone marrow examination to see what is the cause. And as you rightly mentioned, recent data, although the previous data was telling that it is around 25 to 27% of cases having autoimmune cytopenia, but in recent data we see that only 5 to 10% have autoimmune cytopenia, and most of them, almost 50 to 60% of them, they are AIHA. Rest are either ITP or PRCA. So PRCA is very less common. But the good thing is that these cytopenia do not affect the prognosis of our patients. Dr. Dipanjan,
yeah,
in this case, what are your initial treatment options of this patient? So this is FISH negative. He's not got any. We have not got any cytogenetic abnormalities. He is 79-year-old male. So what are your initial treatment options for these patients?
So my initial treatment option in this elderly patient in whom we do not have FISH as well as IgHV mutational status data will be with ibrutinib or acalabrutinib. So that will be my initial preferred option for this patient, specifically because we don't have the data and as well as the tolerability of the immunotherapy agents. So FCR-BR will be slightly difficult in 79-year-old frail patient. So I'll prefer either ibrutinib or acalabrutinib for this patient.
Okay, so this patient was diagnosed as CLL in 2018, and at that time we did not have this cheaper ibrutinib what we are having now. So in that scenario, would you have considered some other drugs for this patient?
So yes, in such a situation, I mean, about 2-3 years back, maybe chlorambucil plus rituximab would have been a reasonable option without lacking the FISH as well as IgG mutational data.
Sure. So if you see the NCCN 2020 data, for frail patients who have significant comorbidities or those who are more than 65 years of age, or even younger patients with significant comorbidities and renal compromise, this is the preferred regime. So we have ibrutinib, acalabrutinib as of now, but if it was not there in that time, and or if the patient was not affordable for that, then we had the options of bendamustine, rituximab, chlorambucil, obinutuzumab, or even single agent rituximab or single agent chlorambucil, because the patient is 80 years of age and he is having a performance status of 2. So so very fine. We had many options, and even if you see the international working group for CLL, the criteria for those patients who are not having any relevant mutations, cytogenetic abnormality, and those who are slow go. Now the recommendation is that you can go for either venetoclax based chemotherapy or ibrutinib based chemotherapy or even chlorambucil plus obinutuzumab. But for our patient, because of affordability, we started on single agent rituximab, that is 375 milligram per meter square, and he received 6 doses of rituximab every 28 days, starting from 13th of June until 1st of November. And you can see that with this treatment, his hemoglobin, which was initially less than 10, it was almost always more than 10. He was maintaining in the range of 10.5 to sometime it was recorded up to 13 and 14 gram also. And till June 2019, he was maintaining a good hemoglobin about 10. But June 2019 onwards, the counts started rising. So initially it was in the normal range, but if you see the TLC from June onwards in 2019, it is progressively increasing, although there was a marked increase from in between. Patient was lost to follow-up also for some times. So we can see that definitely in November 2019, he had a 41,700 and then progressively increasing count, although the hemoglobin was initially maintained, but later on he also developed anemia and thrombocytopenia. So again, Dr. Rajesh Patil, this patient has a disease which is showing, we can say relapse, although we have not done bone marrow to document the remission and or partial response, but yes, by the counts, if you go by the counts, he had a very good response for at least 1 year, and then he started progressing. So he's progressing. How will you approach this patient now?
So as this patient's WBC count has increased and there is a bicytopenia, I will also look whether there is any swelling, means whether there is any lymph node which is very fastly progressing, lymph node or anything is present which might suggest a progression to a high-grade lymphoma. Otherwise, I will again get a workup retic count and DCT in this patient to see whether it is becoming autoimmune manifestation at this point. And again, a biochemical profile, everything, renal function test, uric acid, and a liver function test, again a triple H, and we'll repeat the FISH and TP53 mutation at this point too, so that to see whether any new mutation has evolved in this patient, as well as there is a cytopenia. If the comb is negative, we'll definitely get a bone marrow done.
Definitely, very rightly pointed out. So all the, like a patient at relapse should again be evaluated as you are evaluating at the baseline. So again, even the cytogenetics is to be repeated because newer cytogenetic abnormalities can be gained during the disease progression. So for this patient, and even peripheral smear clinical examination is important, as you mentioned, because sometimes there can be DLBCL transformation or sometimes it can be a PLL transformation. So his CBC again showed anemia and thrombocytopenia with high TLC. There are prolymphocytes which are 10%, reticulocyte is again 1.5, so there is no significant hemolysis. Coombs is negative, and this time when we did the FISH panel for CLL, it is 17p deletion is positive in 60% of cells. So with this information, Dr. Preeti, now what will be your option of treatment for this patient? Now the patient is in 2020. Yeah.
So patient should be 71 years old with no other comorbidities. He does not have any like a cardiac or any other issue. And so at this point of time, ibrutinib will be a good option for him. And with if we find that there is a disease burden which is high in like an abdominal lymphadenopathy or something, so maybe adding a rituximab upfront with ibrutinib might be the best option for this patient now.
Okay. So again, if you go by the guidelines, you rightly said that for relapse refractory patients, again we have the options of acalabrutinib, ibrutinib, venetoclax, and even the PI3K delta inhibitors like duvelisib and idelalisib. And any of these can be used, but as ibrutinib is now easily available to us, so this is the preferred option, I think. So even the International Working Group for CLL also recommends the same things. So patient was started on ibrutinib, which is the standard dose of 420 milligram once a day from 22nd June onwards. And initially he presented with significant discomfort, nausea, was not tolerating the drug well, and he also complained of myalgia. So Dr. Dipanjan, what is the incidence of initial intolerance in your practice if you are using ibrutinib at standard doses?
So the initial intolerance at practice as per literature as well as in my practice is about 15 to 20%. So about a quarter of patients to 1/5 of patients develop some degree of intolerance.
Yeah. And what do you do actually in such situations? What is your strategy, like how you manipulate the doses or how you go about?
Yeah, so most often what we do practically is either reduce the dose or give a brief period of drug holiday, depending on how, I mean, whether we can give drug holiday in such a situation or just reduce the dose based on the counts and how serious the patient is in terms of the disease. So that is what helps in most of the patient. Very rarely we have to discontinue the drug altogether.
Okay. Thank you. Any viral or bacterial prophylaxis you are using with ibrutinib for your patient?
Yeah, so as per the literature, when ibrutinib is used alone, then most often we do not need to give viral or bacterial prophylaxis. However, if it is used in combination with rituximab, then we need to give prophylaxis for standard prophylaxis with rituximab.
Yeah, because the data regarding prophylaxis is controversial. Some of the specialists they try to continue cyclin-DS and acyclovir, not the antifungal prophylaxis, but at least acyclovir and cyclin-DS, especially in relapse setting, not usually in the upfront setting, but usually in the relapse setting. So, but there is a variability of opinion regarding the prophylaxis. Definitely, most of the people, they are not using any prophylaxis routinely. So there is a very good article regarding how I manage ibrutinib intolerance and complication in patient with CLL, and there is a mention that almost 41 to 50% of our patients in the trials also, they discontinued ibrutinib after 1 year of follow-up. So if you see during 1 year follow-up, almost 40% of them, they are discontinuing due to some or the other side effects. So again, as you mentioned, for our patient also, we reduce the dose of ibrutinib to 280 milligram, so two caps daily. and patient is now tolerating it well. So with the 3 months of follow-up, if you can see the recent CBC, which we did it just last week itself, last week or last 2 weeks back, it was hemoglobin was 10.1 and total count is 12,000 with platelet of 1.54 lakh. So the patient is responding to ibrutinib very well. But today we are discussing about acalabrutinib. So this question is to all the panelists. All of you can have your opinion on this. How will you place acalabrutinib? Dr. Hari Menon has very well explained acalabrutinib in his previous talk. So how will you place acalabrutinib in your current scenario of CLL management when you have ibrutinib and acalabrutinib both with you? Dr. Rajesh?
Yeah, so as sir has already shown us that the results are as good as ibrutinib, and along with much better side effect and adverse effect profile. I think, and even those patients who had a significant side effects to ibrutinib able to continue take a acalabrutinib with comfort. I think we can keep an acalabrutinib above ibrutinib at any for any patient for any, even as a first line or as a second line, and even irrespective of 17p deletion status.
Dr. Dipanjan, any comments?
So yeah, completely agree. So all patients with so especially with the 17p deletion or IGHV unmutated stat cells, and should be given option with either ibrutinib or acalabrutinib. In terms of tolerance, acala is probably better tolerated. So definitely we should place it higher and probably offer to all patients.
Thank you. Dr. Preeti, any cost constraints or something?
So I think until we know what is the cost factor of acalabrutinib in India, ibrutinib will be the priority, because we know that it's now very cheaply available and affordable for all patients. And in case as an intolerance to ibrutinib, maybe I will consider acalabrutinib.
Okay. So thank you all the panelists, Dr. Rajesh Patil, Dr. Dipanjan, and Dr. Preeti, for your active involvement in this panel discussion. And I think the purpose of our panel discussion probably to our viewers is definitely successful, and we look forward to Dr. Ase Karpe again. So thank you everyone. Thank you for giving the opportunity, and thank you all the panelists for being with us and actively participating in the panel discussion. Thanks.
Thank you everyone.
Yeah, so thank you very much, Drs. Verma and Dr. Dipanjan, Dr. Preeti, and Dr. Rajesh Patil. It was a really wonderful discussion and insights into CLL management. Now, because of some emergency, Dr. Ganesh is not yet joined, so I will request Dr. Bhausaheb Bagal sir to start the panel discussion about response adapted management in Hodgkin's lymphoma. Dr. Bhausaheb sir is a medical oncologist, associate professor working in the Department of Hematology and Bone Marrow Transplant in PMH Mumbai. Over to you.
Asha, can you see my slides?
No, sir.
So you have to
Actually,
share screen again.
Visible. You again share the screen option, because
Okay, did I?
initially it was visible. That's right,
okay. All right. Thank you, Ashay. Thank you for this opportunity to do this panel discussion. We thought we'll have a good talk by Dr. Ganesh before us, and then we'll move on directly to the practical management. But I think Ganesh is stuck with something, so we'll try and do justice to our panel. I'm really fortunate to have my panelists. We have a wide spectrum of panelists. Dr. Samir Milankari is a senior consultant hematologist and transplant physician in Dinanath Mangeshkar Hospital, Pune. We have Dr. Trinanjan Basu, is a consultant radiation oncologist in Mumbai, and we have Dr. Chandrakant. He is a medical oncologist from TMH, passed out. He is practicing currently in Narayana Multi-Speciality Hospital, Kolkata, West Bengal. We have again Bhavesh Poladia. He is again one of our former colleague at TMH, now practicing at Sangam Cancer Center, Namakkal, Tamil Nadu. We have Dr. Anand Gokan, my colleague at TMH Mumbai. We have Dr. Deepali Borade. She is consultant radiation oncologist at Apollo Hospital, Navi Mumbai. And we have Dr. Hemant Khandare. He's a consultant nuclear medicine physician from Kokila Ben Dhirubhai Ambani Hospital again in Mumbai. So with this, we will move on. I will start with two cases of early Hodgkin disease, and we will see how the difference in patient presentation can lead us to take different choices for individual patients. So first patient is a young Mrs. DN. She is 22, female. She presented with cough and mediastinal mass, and that was it. She had no B symptoms, etc. On the opposite side, we recently had a lady, Mrs. AR. She is 73, female. She doesn't have any comorbidities as of now. She had lymph node in March this year, but because of COVID, she didn't really consult anyone, and the swelling has relatively remained stable now. And now she approached our hospital last month to us. So this highlights the two spectrum of bimodal distribution of Hodgkin disease. And it is rare to have localized disease in elderly people, but we had this elderly lady presenting with that. So these were the PET scan of two patients. As you can see in the first patient, it is really restricted to mediastinum, and it is consistent with the diagnosis of nodular sclerosis variant. And the other lady we just had in the neck, which is going on for last 2-3 months, but not really spread outside. So with this, I would like to have Dr. Bhavesh say on the risk stratification, how we approach early stage Hodgkin disease in the clinical practice.
For early stage risk stratification, usually we have 3-4 guidelines to follow, but most of them follow the 3 points which are common. First is the ESR, which is individually if it is more than 50 or more, or with B symptoms more than 30, that is accepted by all guidelines. Another is the largest mediastinal mass, which should be more than 1/3 of the chest diameter, and this is also accepted by all of them. And whether in either of the high risk factors. And third, which is accepted by all, is the number of nodal region in which is usually more than 2 or more than 3, which is accepted. We have certain other 4 criteria which are found to be individually active but not accepted by all guidelines. Like age, some of them accepted at more than 40, some more than 50. Then certain certain other factors like histology of mixed cell or lymphocyte depleted. There are certain other 2 factors also, but mainly these 3 factors is what I usually see in clinical practice. So if any, yes, sir.
I think excellent say on this. You brought out the point of heterogeneity of the risk factor of different study groups, etc. And this is a common thing. People get puzzled, or many times a student asks us, what do you follow? But I think it is important to follow the risk stratification. If you are going to use a protocol, for example, if you are going to follow a rapid protocol, probably you should take their risk factors or their study population. And if you are going to look at the early favorable as per the HD10 study, so that is one way of doing it. But certain common risk factors, as you had highlighted, really stand across all the study groups. Moving on, we have this important advances. We would say that this is a therapeutic advance because it drives our clinical decision, the interim PET. So we do interim PET on all our patients, and it is prognostic. So I would like to ask Dr. Hemant on this. Means how do we interpret interim PET? What are the advantages and fallacies of same? And do we still need to do an end of therapy PET if we had done an interim PET which has shown a complete remission? So Dr. Hemant.
Yeah. As you're aware that FDG is now commonly used for the PET scan in Hodgkin's lymphoma. So interval PET is normally done after 2 to 3 cycles of chemotherapy. So for interpretation, we are using dual scoring system. We have a 5 dual, we have 5 score. Like score 1 is no uptake above the background. Uptake score 2 is uptake less than mediastinum. Uptake score 3 is uptake more than mediastinum but less than liver. Score 4 is uptake more than liver, it is more moderate intensity, and score 5 is mildly intense uptake compared to the liver. And we are using PERSIST criteria for the interpretation. If there's a complete resolution of the previously demonstrated metabolically active lymph nodes or lesion, we call it as complete metabolic response. If there's a 30% fall in the SUV of previously demonstrated lesion, we call it as an interval response. Uh, Actually, we don't see we don't call partial response in this interim PET because it is normally done after completion of chemotherapy. Uh, if there is no change in metabolic activity, that is SUV or change in size, then it is a stable disease. And if there is an increase in 30% increase in the metabolic activity, that is SUV, then or there is appearance of new lesion, we call it as a progression of disease. You asked me about the advantage and fallacies. In the advantage, it is a non-invasive study. Metabolic changes happens much early than the morphological changes. That's why PET is more sensitive and specific than the anatomical imaging like CT scan, MRI, or ultrasound. And here we are getting molecular information at the cellular level. Okay. The fallacies of the PET is that we get a false positive lesion, like in the infection, commonly COX in the India, and sometime in the sarcoidosis, like inflammation like sarcoidosis and other diseases, we are getting reactive nodes. Uh, flare phenomena also happen if we do PET scan immediately after chemotherapy. There might be increase in the uptake. So we falsely say there could be the progression of disease, but basically it is a false flare phenomenon. Okay, and about the what other question you asked me?
Yeah. So Dr. Hemant, if someone is PET CMR at the interim PET, do you advise doing it at end of treatment for such patients?
No, basically interim PET is it guides us whether given chemotherapy is useful or not. So complete metabolic response on interim PET does not mean there is 100% resolution of the disease, because there's a limitation of the spatial resolution of the PET to detect low metabolically active lesion, residual microscopic lesion. So if there is a complete resolution on the interim PET, you can reduce the number of cycles of chemotherapy, or you can omit toxic drug like bleomycin, or even you can omit the radiotherapy. Okay, but it does not mean that you should stop the chemo treatment after that. Okay.
Yeah, so I think very well said. I think the most important value it gives us metabolic readout of the tumor. And one excellent example for a student in the audience, I will tell you that when the salvage regimen here used in the previous era, when the CT was used for response assessment, their responses in the current PET era jumped by 10 to 20% by simply by the fact that most of the PRs in the past were because of the residual non-viable fibrotic changes. So it is important to do a PET scan in response assessment in Hodgkin disease than any other tumor, in my opinion. And as you had aptly said, and you really brought out the point of doing end of therapy PET, because some of the people would have some changes in that, and there is some recent data showing some discrepancies in the end of treatment versus interim PET. So we move on. This is the management schema for early stage disease. This is a European perspective where they use combined modality treatment in using ABVD and followed by radiation. And if you go to the American, they have two kinds of approaches. One is a patient where preference is given to combined modality treatment, and they will divide patient into favorable versus unfavorable, and they will use the chemotherapy cycles depending upon that, and radiation upon that. After that, radiation will follow. They have this early unfavorable treatment schema where combined modality treatment is there. So basically the number of cycles of ABVD increases here to 4, and after that it is followed by inward side RT. But I think one important difference from the European guideline is patients where a treatment with chemotherapy alone is preferred, and in this patient they recommend doing a PET scan. If it is dual 1-2, you just give chemotherapy, and the cycle will depend upon whether this is a favorable or unfavorable disease, and after that you don't give radiations. So this is slightly change between these two guidelines, and this is a common discussion point in our OPDs with our patients. And on this, I would like to have opinion. I will just review two studies which were done for early stage disease. So the first one, URTC Lisa Phil Esten study, which looked at the PET guided approach of omission of radiation therapy. If you're PET negative, they omitted radiation. If you're PET positive, they gave escalated week of and nodal RT. This was compared with the standard non-PET guided ABVD followed by RT. And this study was stopped prematurely because there was significant difference when if you omit radiation, there were roughly 10% or more than 10% drop in the event-free survival. The UK rapid trial was restricted to stage 1A, stage 2, and DEVIL 1 to 2 people were randomized to IFRT versus no IFRT. So this study showed there is a smaller decrement in the event-free survival, but this was a study of with a non-inferiority design. The study did not end its non-inferiority expectation, and there was some decrement in the event-free survival. But still, it showed that 90% of the people were event-free if radiation was omitted. So with this background, I would like to have opinion of Dr. Samir. For early stage Hodgkin disease, what is his present clinical practice? He use any other regimen other than ABVD, right, be at beginning or after interim PET, and how he handles DEVIL score 4 or 5 at the interim PET?
Yeah, thanks, Bose. So my approach is for early stage Hodgkin's disease, I prefer combined modality treatment. Alternative regimen to ABVD, no, I have only given ABVD so far, primarily because it is easy to tolerate, and also the infertility rate as compared to other regimens where you would use the alkylating agents is much lesser. So I always prefer ABVD, and after 2 cycles of ABVD, I would do an interim PET. And depending upon the results of that, as you had just mentioned earlier, if it's a favorable disease, if it is, the PET is negative, dual 1 to 2, I would prefer to just give radiation therapy and finish the treatment. However, if it is showing a dual score of 4 to 5, depending upon the clinical situation, I might decide to rebiopsy that particular site if it's not been biopsied earlier and confirm whether there's no other disease present at that site. Or I may decide I would prefer to upscale the treatment to BCOP, escalated BCOP, and continue with 2 further cycles of escalated BCOP, after which I would do another PET to confirm what the disease status is and take it forward from there.
Yeah, so I think that's a common practice nowadays in early stage Hodgkin disease, where combined modality is preferred even at our center. And DEVIL 4, 5, there is decrement in the outcome, and as shown in the previous slide, H10 studies, if you escalate to escalated BCOP, you have improvement in the PFS, and the decrement is avoided. But how easy you find to give escalated BCOP in routine
Yes.
practice?
Yes. Yes, actually we've used BCOP per se, not escalated, but BCOP we've handled with good success. Escalated BCOP does tend to be a little toxic, I must say. You need careful patient counseling, because majority of patients are going to become infertile at the end of escalated BCOP. And cytopenias have been a definite problem. Recently, we've faced problems with vinblastine not availability, and we've seen some autonomic neuropathies with the recently available vinblastine. So I agree, it is challenging. But having said that, we've got good experience, and therefore I use it rather comfortably.
Yeah, so I think it depends on the patient in front of you, but sometimes it feels that doing a transplant would be easier than giving escalated BCOP, at least in patients. So that's the main reason people are away from escalated BCOP. But point well taken, that these people have poor prognosis. We need to do something for them. Moving on, I think early stage, the role of radiation is very important. So how radiation has evolved in early stage Hodgkin disease, and what is the current doses you use and technique you use, Dr. Trinanjan?
So radiation has really evolved. Hodgkin disease is a site where premise of radiation has seen everything, from the only treatment modality to large field to coming down to mantle to subnodal to, for a long time we were doing involved field radiotherapy. Till about a decade or so, or less than that, there are guidelines now for further reduction of the fields. So something like ISRT and INRT, all these have evolved. Now, it sounds very techy and very fancy doing INRT. If you see all the PET-based interim analysis trials also, they're trying to compare IFRT to INRT. As radiation oncologists, and to give a message to audience, we have to realize INRT is something which is very precise. In Hodgkin's early stage, it is something that the node just with a margin being treated. But the basic premise of INRT requires you have to do that planning at the baseline. Means when you're doing your first staging assessment PET CT, at that time only in the same setup you have to do a radiation planning as well. keeping in mind that the patient would come back for radiation, and then only you can carry out INRT. The moment the patients have received chemotherapy and then coming, be it favorable, unfavorable, the basic concept of INRT does not apply. So there are a couple of review articles on that. So what we mostly follow is basically ISRT. So ISRT is basically a poor man's INRT, to be honest. With all available guidelines and PET adapted treatment, mostly in early stage we follow ISRT. That's the initial, whatever may be the residual after the chemo, that area plus the initial disease bearing area taking in your CTV with a certain margin. Now, this is one aspect of what the technique to take. Most of the time, 3D conformal would suffice, because the early stage, depending on favorable to unfavorable, the dose range would be between 20 to 30 gray. At times, it just goes around maybe 34, 35 gray around, if they still have some sort of partial response to the stipulated chemo cycles. Depending on the site, depending on the PET response, and which site we are finally end up treating also dictates which technique we have to select. Like doing a neck, a 30 gray radiation also is not a challenge. Most of the, in other head neck squamous cancers, we treat 70 gray, and there the techniques of IMRT and higher techniques come into play, because the organs at risk also will develop acute and late toxicity. In treating a neck for an Hodgkin's lymphoma, early stage is not that of a challenge, because there will be hardly any side effects related to organs at risk, except thyroid, and thyroid is not only dependent on radiation dose. People receiving higher dose also don't develop hypothyroidism. A very simple dose also at times cause. The specific answer to your question, that the toxicity and technique comes into play while treating mediastinum, especially for young males with the risk of developing second cancers, and young females with the risk of developing breast cancers later in life. So even if we prefer techniques like IMRT or so, we have to take care of not to give low dose pill to the lungs, which is the risk factor of developing both pneumonitis as well as later on lung and breast cancers. We have to make specific beam arrangement to avoid low dose pill to these structures. So in a simple line, even a 3D conformal would suffice, because the radiation side effects are dependent both on the dose total delivered and the structure surrounding involved. So even a 3D conformal would do. But once you have available techniques and you're cautious on these planning aspects, so maybe for specifically for thorax and some part of abdomen while treating, where you have mobile organs at risk surrounding area, IMRT and other techniques, and people have gone to move also doing breath hold technique scans, a DIBH technique like otherwise we treat for breast cancers, may be considered in these cases, because these cohort will live really long.
Yeah, thank you. I think that was a really clear message. One question I have to ask you is, you said you require to plan at baseline. So you mean
for INRT?
Yes. So we really, most of the patient, we do a PET non-contrast CT. Is it sufficient, or you need something more than that? Because they would be seen by a hematologist or medical oncologist in day one and may not be coming to you. So what's the message you want? Is that imaging sufficient?
Not really. And the other point, to tell you honestly, personally, I don't have any INRT experience, and I doubt even, I guess if Dr. Lashkar, if sir is planning any trial in TMH, then it is done from the beginning. I'm not aware any INRT trial going on, and that's why there are guidelines. We have an ILROC Society, International Lymphoma Radiation Oncology Group. So they also advocate rather doing ISRT, because from a radiation perspective, between an INRT and an ISRT, like an involved node and involved site, there's not much of a volume change. The volume increase from INRT to ISRT is really not substantial, like between IFRT and ISRT.
Yeah, so
to be
ISRT is good enough, and you are
good enough. Yes, yes, yes.
Without contrast. Okay, thank you. That was really nice message we received, Triranjan. We move on.
Thank you.
I really want to ask Anant. Anant, all these people are early stage disease, and if they relapse early, and let's say that we have avoided radiation in their treatment, do these people have different prognosis when you want to salvage them as compared to a person who has received the full treatment and then has relapsed? Anant, can you hear us? Yeah, I think Anant.
Yeah, can you hear me now?
Yes, Anant, we can hear you.
So, approach to early stage Hodgkin's relapsing is quite similar to those with advanced stage, and if they have relapsed early on post primary therapy, it means that they are relatively chemo resistant and they would require a high dose chemotherapy and transplant.
Yeah, Anant,
But
I was asking one particular question. I mean, one particular point is that
yeah,
if we treat early stage patient with, let's say, without RT, okay, and we said that the treatment was really not intense, and if these people relapse not early, but maybe whenever they have to relapse, do you think this relapse would be easier to salvage than the
yes.
typical
So,
full
so
full relapse?
early stage relapses are a bit easier. The response rates are better, and the survival is also better compared to advanced stage at relapse. So that has been seen in the even in the GSSG data. So in terms of prognosis, they are easier to treat and they have a better survival.
Yeah, but Anand, you will still take them for salvage chemotherapy and transplant, or any subset where you would kind of avoid transplant in case of relapse where the initial treatment was really abbreviated or it didn't include
So
radiation.
if it's only a neck node, single node, and it's a early stage neck disease, then only radiation may be tried. But many of these patients would eventually relapse and require high dose chemotherapy and transplant.
Yeah, I think Anand nicely brought out the concept of coming as I mean, there is no favorable relapse, but the favorable relapse coming, especially in the pediatric age group. So that is one thing we have to keep in mind. So Anand, we'll move on to this. So this is the these are the two patients. So one is a young lady who has a mediastinal disease, and another is an elderly lady, 73, who has a neck node disease. And I want opinion of Bhavesh. How would he manage these two patients? And as a medical oncologist or hematologist, and Dr. Deepali as a radiation oncologist. So Bhavesh, one line
So,
answer for DN. What is your choice, and for AR, what do you think it be better?
so I think for both in my practical this thing, I would have used ABVD only for both. Uh, that would be my standard to start with
And
because
about radiation, what do you think you do with radiation? Bhavesh, would you add
yes.
radiation to these people? Means would you use combined modality, or you will just use chemotherapy?
So in practice, we were using only single modality chemotherapy because most of our patients after counseling, were few of them were not even ready for doing a PET interim, and those who were, we were asking them to go to some other center because we did not have a radiotherapy center, a radiotherapy machine with us, so they were even not ready to go to some other center. So initially we were not, but now we have a radiation machine, PET scan machine both in our center. So now we are next patient. I think I am going to offer multi-modality treatment, bi-modality treatment.
All right. And Dr. Deepali, from radiation perspective, what do you think should be the approach to these two patients? We can't hear her. Is she mute?
Okay, sorry. For patient, DN patient, she is a young patient. So after chemotherapy, we can discuss with the patient because if she is a young, early stage, favorable disease, and even in unfavorable disease, after complete response, we can give the option of radiation therapy. Just because this is a mediastinal and not bulky disease, we can defer radiation in her. And the second patient is a young patient in which the disease in the neck and which can easily irradiated with the proper dose. And if that old patient is having comorbidities, which is for which she's not a fit candidate for chemotherapy, then definitely we can treat radically with the radiotherapy.
Yeah, I think these two patient profile highlights one patient where the risk with radiation is probably higher than the other patient. In fact, the other patient, this is a real world patient, 73, and I had a difficult time planning her chemotherapy because of various risk with the chemotherapy. But I agree. In first patient, we have to discuss the pros and cons of radiations and the decrement in the PFS if you avoid radiation, and we should have ability to salvage such patient when you want to avoid radiation. That is important. For the AR patient, I completely agree. Radiation is important part and probably the easier part to do, and chemotherapy definitely we will add if that's feasible in her. We move on to advanced stage. Advanced stage things are a bit less complicated in my opinion, because approaches are very separate. There is ABVD based approach and there is escalated BCOP based approach, which has probably not really popular recently. So this is European perspective, and if you see the American perspective, they favor ABVD, and they kind of do interim PET, and after that they also seems to have applied the Rathil approach of dropping bleomycin in patient with CMR. So this slide summarizes the studies of advanced Hodgkin disease where PET adapted treatment has been done. And in Rathel, in patient with dual 1 to 3, 4 cycles of AVD after initial 2 cycles of AVD suffice. This study did not show any harm of omitting bleomycin, and that avoids lung toxicity. Similarly, dual 4 and 5, there was escalation or to escalated VCOP or BCOP, and that led to doubling of outcome from 30 to 67% in this patient failing early PET. HD18, where you would start with escalated BCOP, and where you could do away with 4 cycles of escalated BCOP if your dual score is 0 to 2 after 2 cycles. In dual 3 to 5, 6 cycles are good enough, and there was no benefit of rituximab. Again, the similar study AHL 2011 Lisa group. So dual 1 to 3, if you start with ABVD and if you are negative, you could just complete your remaining treatment with the 2 cycles and ABVD, and that should suffice. In dual 4 to 5, they give 2 cycles of escalated BCOP and the outcome improved. So this study mainly shows that if someone is failing interim PET, they probably would be salvaged by escalated BCOP, and I think that's one important treatment change or message we have here. So advanced stage disease, I would like to ask Dr. Chandrakant, how do you choose the different regimens, ABVD, escalated BCOP, the recent brentuximab vedotin, AVD, echelon 1 data, if let's say that a person is fit and doesn't have financial constraint, and how he decides on the interim PET negative versus positive patients?
So, sir, as you said in the previous slide, the Rathil data is very promising, especially in the Indian setting. First, we have to risk stratify as per the IPS Hessen curve. If it's a good risk, giving ABVD would be equivalent. We will start with ABVD for 2 cycles, and then we will do an interim PET. If there is complete metabolic response, then we can omit bleomycin and give only ABD, and the results are as good as giving ABVD. So if it's a good biology disease where we have got a CMR, after 2 cycles of ABVD, we can omit bleomycin. And then supposing we have a poor risk disease, not in our setting at least, it would be reasonable to give escalated BCOP, but because of limitations in our setting, it is difficult to offer escalated BCOP because of this present COVID era and also because of difficulty in handling febrile neutropenia. So in poor risk, if you look into the evidence, we have some overall survival benefit. There is a meta-analysis suggesting escalated BCOP giving some PFS and reasonable OS benefit also, but in practice it is not feasible. And then, so if post 2 cycle ABVD, if there is no CMR, insufficient response, yes, we have data from Rathil again where we can escalate to escalate BCOP and then get the optimal response. So that is about escalated BCOP. Poor risk upfront we can use, whereas in good risk we can use ABVD. Suboptimal response we can exclude escalated BCOP. And then coming on to adding brentuximab, yes, very assuring data. Again, in poor risk disease, they have done very well, but again, it is not that non-toxic at all. Even there also a lot of neuropathy, lung toxicity, neutropenia was seen, not as easy as handling. Of course, less toxic than escalated BCOP. So if there is prospect in a patient where I cannot use bleomycin, and if a patient is less than 60 years can afford, I would not hesitate to use brentuximab along with AVD. Again, we don't have a head-to-head comparison between escalated BCOP and BV AVD to answer the question which one is better in the poor risk. So PET will decide me whether to de-escalate or escalate the treatment after the AVD.
Yeah, Chandra, I think very well put. So if you use escalated BCOP, probably the initial drop with ABVD is prevented. So as said that it probably has some advantage in patient population where there is high acid flavor index. And BB, as you said, probably is not a really gentle regimen, and febrile neutropenia. Yeah. So it's really a choice, so we have to choose, and probably we need to see more data with BBAVD. It's non pet adapted therapy, so if you are not going to do that, that's probably one way to go. And I completely agree with your take on pet positive and negative patient of dropping bleomycin and escalated to BCOF if that's feasible for pet negative and positive patient respectively. We move on in advanced stage disease. I think this is very important where we are really dropping the drugs and adding chemotherapy, which is really toxic. So I want to have opinion of him and Miss. Besides staging, do you have any additional information to guide us on deciding how to treat these patients at the baseline? Second thing is prognostic value of interim PET, and does it differ with the treatment we are using, for example, ABVD versus escalated BCOP in this advanced stage disease setup?
Yeah, PET can predict treatment response and long-term outcome. Early stage Hodgkin's lymphoma carries excellent prognosis. So in interim PET, if there is a good interval response, that is dual 1 or 2, then prognosis is excellent. And if the interim PET shows no interval response, that is duals 4 and 5, then prognosis is not good. In such cases, then I think we'll have to change the chemotherapy drug from ABVD to EBCOP or other.
Yes, Hemant, I think very well said. This is one important advance, may not be directly contributing to treatment, but this is definitely we have to do in each and every patient. And probably I will value this as the most important scan in patient with Hodgkin disease besides the baseline scan. We move on, advanced stage Hodgkin disease, and I would like to ask Dr. Dipali the role of radiation therapy in advanced Hodgkin disease.
So for, as like early stage early stage Hodgkin's lymphoma, the role of RT is also evolved in advanced Hodgkin's disease. Due to toxicities, the indications are decreased, but still in PET positive residual disease, which is more than 2.5 centimeter or equal to 2.5 centimeter, we'll consider RT in that cases. In pre-interim PET era, for bulky disease also, and in the disease which is in which mediastinum to thorax ratio is more than 1/3, the radiotherapy was indicated. But after interim PET CT studies, they have omitted the radiation therapy. But in last year, ISTRO 38, they have published one randomized study in which they have showed, it is a HD801 trial, which showed that there is a 7 to 10% benefit in the 3-year and 5-year 5-year overall survival, 5-year survival. So again, it is an indication for the bulky disease and where the mediastinal disease is more than 1/3. Also in rare situations like where the abbreviated chemotherapy used, like Stanford 5 regime, in which the radiation is the part of the treatment modalities.
Yeah, I think very well summarized. So bulk remains a risk factor. I think it is one of the important risk factors, and there is a good help of radiation in preventing the relapses there. And definitely residual disease is the most strong data. So we should not forget.
Can I make a comment?
Yes, please.
So I agree with Dipali, and just to highlight, to give a message, there's one 10 years follow-up data recently published from the Stanford itself. So Richard Hoppe is one of the pioneer radiation oncologists in lymphoma. So everywhere, wherever in advance the radiation was skipped across all stages, we get this 10% plus relapses where it is omitted on as a detrimental. So even in the modern era with adding the PET value, I guess we all end up practicing to the either the residual or to the initial bulky site until that bulky site is mediastinum where their concerns of all lead toxicity on arise. If that bulky site is neck, I think we should still strongly practice giving radiation after the stipulated chemotherapy.
Yeah, I think that was important point that the Stanford 5 earlier with radiation and without radiation had shown the value of radiation. So thank you for bringing that out. And we'll quickly move on to relapse setting now. How do you choose salvage regimen, and do you use interim PET Anant, means PET after salvage chemotherapy and before transplant to guide your decision?
You have 5 minutes to wrap up, sir.
I think this would be last but one slide, so we're done.
Yeah, so regarding how do we choose salvage regimen depends on multiple factors, including the patient's previous regimens, what comorbidities he has, and what has been his tolerability. In general, the most important thing that has to be seen is it should give good CR rates and should have good potential for mobilization. So the most popular regimens are minibeam and dexabeam. Although they have good response rate, they are relatively difficult to mobilize stem cells after such intensive regimen. And per se, there are no head-to-head trials which have shown that these regimens are better than either GDP or MINE or ICE. So we can actually choose any regimen, but we have to ensure that we get good mobilization. So for us, we prefer GDP regimen. If GDP is not possible or ICE, we do not prefer mini beam or dexa beam because of the difficulty in mobilizing stem cells. Because most of these patients would end up being transplanted. So
Anand,
the
what do you do
choice.
if IPET is, your pet is positive after salvage? Do you give another salvage or you just plan transplant?
So if PET is positive after salvage, we do biopsy to ensure that this is actually disease and nothing else. And if it is disease, then we salvage the patient. At least we try to salvage a patient with another regimen before we take him up for transplant.
Yeah.
Because it is shown that those who are PET positive tend to have worse outcomes compared to those who are PET
I think
negative.
response adapted treatment is there also very well brought out, Anand. We'll move on quickly in view of less time left. So in relapsed Hodgkin disease, do you think there is any role of radiation, Dr. Dipali?
Yes, we can use the RT as a consolidative RT where the disease is present in the single node or it is well included in the single RT field. So before transplant, along with the salvage therapy, we can use the radiation. Also, there is a role of radiation for the palliative setting also. And in patients, we are unfit for the salvage therapy or transplant. There we can use the radiation therapy.
Yes, I think we have.
Also, with the advent of immunotherapy, again the role of radiation therapy is coming into play.
Okay, all right. So I think that was interesting point. So we, I think, end with this, and I thank Ashay for giving the opportunity, and I really want to thank all my panelists for bringing out the discussion very well. Thank you, everyone.
So just one question.
Thank you.
How many, I mean, Dr. Samir Melinkir sir is there also. Even we have, combination of hemat and onco both. So anybody using ELN guidelines, especially in adolescent sets of patients, because we see, I mean, like hematologists, in fact, will see more of a pediatric patients also, and they're actually treating Hodgkin's. While as a medical oncologist, now we have like a distinction between, like the pediatric versus adult. So we really do not so, but anybody following ELN guidelines, because there even in early Hodgkin's, we do not see that much role of RT, if we are looking at in especially pediatric protocols.
Yeah, I have no experience.
That's why I said that's the reason I said Dr. Samir or anybody, Dr. Puneet is also there. So are you using ELN guidelines by any chance, OIPA, OPA protocols? I mean,
so actually now I too am sort of kind of transferring my pediatric patients to the pediatric oncologist.
Okay. Because actually I just been through, because even I have stopped now practicing onco. I mean, besides age of 15, so Dr. Even Kandan is also there. So anybody practicing ELN guidelines, because if you look at the ELNs now, we have like separate, totally different classifications for both girls as well as the boys. You have OIPA for boys, OPA for girls, and then again after 2 cycles. So in early stage, virtually there is no RT. Actually, what we
no
see
RT in the pediatric protocol. I would agree.
Yeah, so there is no
it doesn't have.
RT, which
So
is
I'm just following the protocol there.
Yeah, that's
so
what I'm saying.
IPA followed by.
And the adults, what we see, where in adult you will use a bimodality, but while in pediatrics, definitely they are getting away with RT actually.
Yes, without the RT.
So, wonderful to have you, all of you, on the same platform. Now we will move to the next session. So I will welcome Dr. Puneet Jain. Dr. Puneet Jain is a consultant hematologist at Apollo Hospital in Belapur, very good friend of mine. Thanks for accepting this invitation. He'll be speaking on molecular classification of DLBCL. So no, DLBCL, we always say, no, it is not a single disease. It's a heterogeneous disease. We always say that, you have double expressor, triple expressor, double hit, triple hit. You have ABC, you have GCB, but what happens actually at the end in the clinic. I think that is what Dr. Puneet is going to summarize. So over to Dr. Puneet Jain.
Is my slide seen?
Yeah, Puneet. Go into the presentation mode.
Right. Is this clear?
Yes.
Yeah. Okay. So, firstly, thanks a lot to Ashay, Dr. Bausai, and Dr. Vivek, and it's really great to be on the same platform where with so many elite panelists and good discussions going on. You know, as we discuss, we realize there are so many things which we learn only through discussions and not by reading. So similarly, this topic today that I have received, it's obviously there is a lot going on in this, and you know, I have around 13 to 15 minutes. I'll try to sum up as much as I can in this time that I have. So my topic is there true clinical benefit by molecular classification of DLBCL? Now we know DLBCL accounts for 30 to 40% of the non-Hodgkin lymphomas, once even considered to be a single disease, but novel insights into its biology has actually revealed that it's molecularly heterogeneous in nature. Now, most patients can be cured using the current frontline chemoimmunotherapy such as R-CHOPs. However, 30 to 40% of the patients have a disease relapse and are refractory to the first-line treatment. Standard salvage approach consists of an autologous stem cell transplant, even if long-term disease control is achieved in fewer than 50% of the cases. Now, survival is particularly poor for those patients who relapse within 1 year after R-CHOP, with fewer than 15% of the patients achieving a durable remission from there. So if you look at the standard prognosticators for DLBCL, we are used to the IPI. The prior to therapy, the usual prognostic scoring system is the International Prognostic Index, IPI, which is based on four or five clinical markers and pre-treatment parameters, but that does not actually look at the biological characteristics of the tumor. Molecular methods have brought in a new definition of DLBCL, demonstrating molecular heterogeneity within morphologically looking similar tumors and linking the GEP or the gene expression profiles to prognosis. Now, using these approaches, there are two main subgroups of the DLBCL displaying different outcomes after chemotherapy have been described: the GCB group, the germinal center B cell group, and the activated B cell-like subtype. Now, this is a diagram of a lymph node, and you can see this heterogeneity is thought to arise from the diverse origin of lymphocytes, and mainly owing to the antigen that is exposed for the B cells transiting through the germinal center. The naive B cell entering the node and the germinal center, and undergoing somatic mutation, developing high affinity antibodies, and then differentiating into the plasma cells or the memory cells. So GCB, like DLBCL, are thought to develop from B cells that lack markers of early post-germinal center cells, whereas ABC, like DLBCL, they display a transcriptional signature similar to the cells before the plasma cell differentiation. Now, DLBCL of the GCB subgroup accounts for around 50% of the DLBCL and is associated with a better outcome in most of the patients. And the tumor cells have a healthy germinal center B cell GEP. The ABC accounts for the 30% of the cases have a poorer outcome in comparison to the GCB subgroup. These tumor cells have a healthy peripheral blood activated B cell GEP, in particular NF-kappa beta signature, which is more predominantly seen in the ABC subtypes. The remaining 20% of the DLBCL are unclassifiable and associated with the ABC subgroup as non-GCB forms. Now, using CHOP-like chemotherapy, the 5-year overall survival rates of patients with GCB signature and of patients with ABC profile are around 60 and 30% respectively. Now, GEP through microarrays pose a challenge because it is available only for a small fraction of patients whose mRNA can be extracted from the fresh or the frozen tissues. and attempts to substitute that GEP with the IHC applicable to the formalin-fixed paraffin embedded tissues have again had their set of difficulties linked to the variability of the results. And when these two techniques are compared, it was evident that the classification of the DLBCL based on COO, the cell of origin, was different. There was another approach called as the Lymph2CX, which was proposed for the GCB ABCCO classification based on a pattern panel of certain genes, and it was applicable to the mRNA that was extracted from these tissue samples. It is conducted on a nanospring platform, and it replicates the results of the conventional GEP. Now, obviously, these things are out of reach for clinicians as of today, but it's important to know that there probably in the future this should be available soon. So now looking at the CD10, if a CD10 is positive, it shows us that this is probably a GCB. This is mostly a GCB type of a DLBCL. If your BCL6 and MUM1 are positive, it's a non-GCB DLBCL. And these are the genetic signatures for the GCB and the ABC for a Lymph2CX digital co-expression platform. Now, this was the summary of the most relevant recent studies about the DLBCL classification and prognostication. Reddy et al. Had actually done a genomic sequencing around 1,000 cases of DLBCL and identified 150 driver set genes and defined that those with a MYC mutation or an aberrant expression had the worst prognosis, and CD70 aberrations had a better outcome. Schmitz et al. Again did a whole exome sequencing, and they classified the groups into 4 genetic subtypes: those with MVD, those with BCL6, those with Notch1, and those with EZH2 mutation and BCL2 translocation. So those with the EZB and BN2 had a favorable outcome, and those with the MYD and the Notch1 had a notch mutations had of inferior outcomes. Again, there was this paper from Chapu, which again showed and classified 5 DLBCL subsets: Notch2, TP53, P10, BCR, NF-kappa-BT, NF-kappa-beta, and RAS, JAK pathway, and C5, which was BCL2 MYD classification. So again, so like this, there were a lot of classification that are there and are being explored more and more. To sum it up, ABC DLBCL and GCB DLBCL, ABC will have either a BCL6 or a MUM1 positive, and the predominant genomic alterations that you have is a constitutive NF-kappa-beta activation. You have a chronic active BCR signaling and a MYD88 and CD79B mutation, a Notch1 mutation, Notch2 mutations, and TP53. A germinal center DLBCL will be CD10 positive, and again, it will be predominantly at least 20 to 25% will have EZH2 mutations. Then there are P13 kinase pathways, mTOR pathways, JAK2 pathways, and the other subset, that is the double hit lymphomas, which are MYC and BCL2 translocation positive. Now, these are important because that probably has set the stage for the next evolutionary treatment in the form of targeted therapy. So this was again the paper from Chapo, which had shown the JAK-STAT pathway and the BCL6 structural variant showing a low risk for genomic signatures. So in addition to that, there was this liquid biopsy, which was a tool probably likely to be the tool that could render the NGS investigations more feasible and realistic. So analyzing these circulating cell-free DNA by looking at the cDNA that was released by the tumor cells, liquid biopsy is a non-invasive investigation that, joined to the NGS sensitivity, will probably revolutionize cancer diagnosis, prognosis, and treatment. However, obviously, we are far from this. So if we look at the DLBCL classification as a whole, we look at the IHC, we look at the IPI, we look at the FISH, we can look at the genome expression profiling, and then the minimal residual disease or chemoresistance emergent pattern can be looked at through the circulating DNA through liquid biopsy. But what we are currently doing is obviously this. We again go on the morphology, an aggressive morphology. Then we look at the COO, that is the CD10, BCL6, MUM1, looking at the prognosis based on the KI67, if MYC and MYC, the BCL2, and these are the markers that we are currently doing. So any aggressive lymphomas, which are, they're classified as GCB positive, and then if MYC or BCL2 is positive by IHC, we call it a double expressor lymphoma, and those which are positive on FISH for MYC, BCL2, BCL6, we call it a double hit or a triple hit lymphomas. So looking at the individualized treatment approaches, so it's the era of risk-adapted therapy. Upfront therapy in previously untreated DLBCL R-CHOP remains the backbone, with the total number of cycles and additional radiation dependent on the stage of presentation and tumor bulk. And this approach can achieve durable remission in up to 50 to 60% of the patients. Addition of high-dose methotrexate also independently and significantly improved the prognosis of patients with high-risk DLBCL, irrespective of the risk for CNS relapse. And numerous efforts to actually improve upfront R-CHOP, including increased dose density with 14-day cycles, use of other CD20 positive molecules like obinutuzumab in place of rituximab, or intensification of the therapy like the dose-adjusted epoch have been made, but have generally failed to show significant clinical deficits. Now, looking at the molecular features upfront, we do know that the upfront R-CHOP produces poor long-term outcomes in the double hit or the triple hit lymphoma, and the rarity of this entity has actually precluded robust prospective data to help establish an optimal induction regimen. So multiple retrospective studies suggested that intensification upfront chemoimmunotherapy may be superior to R-CHOP, which has been confirmed in systematic review and meta-analysis of 394 patients from 11 studies. Yes, there was a majority improvement was in the progression-free survival than in the overall survival. So overall, a multi-center retrospective of 311 patients with previously untreated DHL double hit lymphomas who were treated with induction therapy plus autologous transplant at a median follow-up 23 months had also shown that the median progression-free survival of patients those receiving R-CHOP was 7.8 months compared to 21 months for more intensive regimens such as R-EPOCH, R-CODOX, M, IVAC, and R-Hyper-CVAD. So this was a landmark study from Landsberg who had shown the outcome of patients with the double hit lymphoma who achieved the first remission. The first on the left is all the Kaplan-Meier graphs. On the top, A and B are a group of two groups. Mainly, the entire up is the intensive regimens, and the other one lower down, the blue line, is the R-CHOP regimen. As you can see, those with intensive regimen have a higher relapse-free survival in comparison to R-CHOP. And these are this is a collection of R-Hyper-CVAD, dose-adjusted epoch, R-CODOX M, and this is R-CHOP. Again, this is just a sum of the same, a better relapse-free survival and a better overall survival. What was also important is those patients of double hit lymphoma who went on to have autologous transplant did not show much difference after receiving an induction therapy with intensive regimen like an R-EPOCH. But those who had actually received R-CHOP as an induction regimen, but when they went on to an autologous transplant, they showed an improvement in the relapse-free survival and the overall survival as shown by the yellow line. So blue line is just R-CHOP without transplant. This is R-CHOP followed by an autologous transplant. So autologous transplant may not be the best therapy for patients with aggressive DLBCL, aggressive DHL or triple hit lymphomas based on these studies, available studies. Now, what are the actionable therapeutic targets that have been identified within the GCB-like subsets? Among the best characterized is the EZH2 mutation, which is probably seen in around 20% of the DLBCLs, which are GCB-like. So this regulates the epigenetic programming in germinal center B cells through histone methylation, and which can lead to aberrant silencing of the anti-proliferative genes. So tazemetostat is probably the first class selective inhibitor of this drug, which has shown some response in phase 1 clinical trial. A subsequent phase 2 study also showed activity in the relapsed refractory GCB like DLBCL. If you look at the ABC type of lymphomas, there have been efforts to improve this therapy through combined biological agents, ibrutinib, bortezomib, or lenalidomide with R-CHOP with varying success, on the understanding that ABC disease is driven by dysregulation and constitutive activation of the B-cell receptor signaling. So ibrutinib targets the BTK in the BCR signaling, bortezomib puts the brakes on the NF-kappa beta, and obviously lenalidomide is a mystery drug. Its pathogenesis still not completely clear. So this was the study by a randomized study where ibrutinib was combined with R-CHOP. Patients were randomized on a 1-to-1 ratio of ibrutinib, 560 milligrams of orally plus R-CHOP or placebo versus R-CHOP, with the primary endpoint being the event-free survival in the intention to treat population and the ABC DLBCL. And secondary endpoints included the progression-free survival, overall survival, and safety. 838 patients were randomized, almost equal, 419 in each. Median age group was 62, and 75.9% had ABC subtype disease, balanced baseline characteristics in both. Ibrutinib did not improve the EFS in the intention to treat analysis or the ABC. So ibrutinib actually did not show improvement, but there was a catch. A pre-planned analysis showed this. This was the intention to treat analysis, and this was less than 60 years patients. Ibrutinib, when combined with R-CHOP, had shown a superior event-free survival and an overall survival in those patients who were less than 60 years. The reason attributed was probably the excess toxicity in the higher age group. When R-CHOP was combined with bortezomib in the ABC subtype, there was bortezomib was given as 1.3 milligram per meter square intravenously on day 1 and day 4 on 6 21-day cycles of standard R-CHOP alone. So there wasn't much difference in the progression-free survival or overall survival in those patients who who had received this bortezomib plus R-CHOP in these patients. The third was the lenalidomide. Lenalidomide, a phase 2 study where 64 patients were enrolled, 60 were evaluable for response. Overall response rate was 98%, with 80% achieving complete response. Event-free survival and overall survival at 24. Event-free survival and overall survival at 24 months were 59% and 78% respectively. So R-CHOP patients, 24-month progression-free survival and overall survival was 28% versus 64% and 46% versus 78% in the non-GCB versus GCB. So GCB had a 64 and a 78% survival, and non-GCB had a 28 and a 48% survival. But what was important was there was no difference in the 24-month progression-free survival for OS for R2-CHOP. That's what we call R-CHOP with lenalidomide on the basis of GCB versus non-GCB, 60% versus 59% at 2 years respectively. This was important. Now, there is a new kid on the block, probably partly new, but venetoclax plus R-CHOP in the non-Hodgkin lymphoma, which these were the results from the Cavalli phase 1b trial. This 56 patients were enrolled. Most of them were follicular, but there were 32% DLBCL. Dose-limiting toxicities were reported in 3 of the 14 patients at the first venetoclax dose, after which dosing was changed from daily to 10 days per cycle and escalated to 800 milligrams. Cytopenias were the most common cytotoxicities that were seen and occurred at a definite higher rate than expected, particularly in the G-CHOP arm, but then G was later on converted to R. So overall response rates were as high as 87.5%. What was notable is that 7 of the 8 DLBCL patients with the poor prognostic double expressor phenotype achieved complete remission, a clue to probable potential treatment for DHL and DEL patients. So this was a beautiful diagram which I thought that I should put it and show it to you, courtesy Charles Herbox and Matthew David. So venetoclax is actually driving the NHL towards apoptosis, concept of chemosensitization. And the paper was obviously widely received. And the key points for venetoclax was R-CHOP demonstrated manageable safety and promising activity in B-cell NHL. The recommended dose was established 800 milligrams, a whopping cost in India, probably 5 lakh to 4.5 lakh per month per cycle. You can imagine the economic consequences of the same, but it showed some kind of response. These are all the newer drugs that are in the market, nivolumab and pembrolizumab and venetoclax, which are probably being used as in the relapse refractory patients with lymphoma. Now, despite discovery of new drugs, R-CHOPs remains the standard treatment approach. Targeted therapies considered mainly for relapse refractory patients. This circumstance will probably persist for a while till the biological background becomes clearer, genome-wide sequence becomes within everyone's reach, and targeted drugs have demonstrated the real benefits, most important, within our economic reach. Only then personalized medicine will become feasible for DLBCL. Thank you. I think I've completed on time.
Yeah, thank you very much, Puneet. Thank you for having this wonderful insights about molecular classification already DLBCL and the clinical applications. Definitely, it's a beginning. I think to reaching a clinic and making it feasible is still is yet to reach. So now I invite Dr. Vamshi Krishna. He's my senior at Tata Memorial Hospital. He's a great orator and great moderator altogether. He will bring out all burning points. Whatever are required. So I invite Dr. Vamshi Krishna. He is senior consultant medical oncologist at Hyderabad Apollo. So over to Dr. Vamshi. Please invite your panelist. And I will request Dr. Puneet also to stay back.
So ragging continues.
Dr. Puneet, I request you to just stop sharing your screen so
I'm
that
sorry.
I can.
Yeah, 1 second.
Good evening, everyone, and thank you, Asha, for calling me and for those very warm words. You have put me under a lot of pressure by saying all these things. I don't know if I can live up to your expectations. And
That's
more
the style.
importantly, all the expectations given by Dr. Puneet in his excellent talk that he has talked about all of these. Right. So just a second, let me share my
Just 1 minute. Where stop video? No, 1 minute.
Hey, it's fine. It's done. It's done.
Okay.
So this is. Yes, I recall upon my panelists, Dr. Srivastava sir from Mumbai, Dr. Kunal Sehgal from Mumbai, Dr. Shruti Kate from Nasik, Dr. Srinath Shirsagar from Mumbai, Dr. Hollis D'Souza from Mumbai, and Dr. Vijay Sharmangar also from Mumbai. I hope everyone is there. All the 6 panelists are available. Great.
Yes, sir.
So,
thank you.
Okay. It is now 7:49 and I will stop exactly in 20 minutes by 8:10. Right. So starting off with the case scenario with diagnosing DLBCL, Dr. Kunal, how would you start by diagnosing DLBCL? Would you go only with an IHC or also with the molecular test upfront?
Thanks everyone for having me here amongst a great panel of clinicians today. It's interesting to learn from the other side of things. It's always very, very helpful. So DLBCL generally, from a perspective, most commonly we see it on a lymph node, and the second follow-up is staging marrows, and very rarely on the peripheral blood if there's a spill and you do a flow. So typical picture commonly done is IHC is the most commonly thing done. But in today's day and age, I think we need to follow up the IHC with FISH analysis at the least. The NGS testing, which Puneet just showed, is often not available easily. The panels are not being done. The sample tissue processings are big problems. So I would suggest a combination of IHC with FISH testing to know the double hit, double expressor kind of a picture is what is warranted.
So in your practice, what do you normally see? Would you suggest to the clinician that in all cases just go ahead and do this molecular test, or do you wait for the clinician to get back to you and say, please do a molecular test for me?
So this is a very difficult question as far as the double hit or double expressor phenotype is concerned. One, there are no definite guidelines to which case warrants a FISH and which doesn't. And then in an Indian scenario, especially in a private practice, the cost decides everything very often.
How much is the cost of a FISH test? I'm sorry for interrupting. Generally, what is the cost?
The FISH test on a liquid sample would be somewhere around the range of roughly around 5,000 rupees for a single marker. But if you do it from a fresh frozen tissue, it will be in the range of 6,000 to 7,000. This range will change from institute to institute. Plus, if you do a package of 3 markers, 4 markers, it might be at a discounted rate. So it sort of costs 10 to 15,000. It's not very expensive. But upfront, when the patient sends and he has to do a lot of tests upfront, it becomes a little tricky. So that's where it comes.
Okay, so in my hospital, the IHC 8 IHC package costs 11,000. So honestly speaking, I think cost is something which is important, but if it is really warranted, we should push for it, because I have found out it's around 12,000 in one lab, it's 18,000 in the other lab, which is not
too much.
Not too much, especially if you consider the cost of therapy of. Yes, Dr. Puneet.
So, I know we are, we need to diagnose, but tell me, how are you going to actually approach a DEL and a DHL differently?
Next time, that will come later. You are jumping the gun. Let's first start that you have seen a patient, Dr. Kunal sends you a report saying it's a DLBCL. And
on a report, we advise, based on the IHC, we'll advise that FISH testing is to be done. This is what we do.
Fair enough. So, Dr. Puneet, what would you do? Would you agree with whatever the Dr. Kunal tells you, or what would you look at before deciding on a FISH testing?
So, normally, based on a MIC positivity, if you want to characterize, we would obviously get the BCL2, BCL6 and try to characterize it for a DEL.
IHC, would you look for a DEL first before going for a DHL, or would you simply say, any patient of CMEC positive, I want it?
No, so first is obviously the IHC.
Right.
And then go for, if the economic considerations are there, we are helping, we are doing a favor by knowing whether it's a DHL or a THL.
Then you will do it. Fair enough. Dr. Shruti, you work in I will call it a tier 2 city. So would you decide on doing a molecular test for everybody, or how do you decide?
Like case to case basis, I would, based on the IHC, I would want to do a fish at least for 2 more markers and confirm.
Okay,
And
what is the
see
confirmation
cost.
that you're looking at? I mean, just asking you, not a interrogation. I just was curious as to decide, how do you decide on this? So would you ask
Is
for
it
all
only
100?
is it only a double expressor, or is it a double hit or a triple hit DLBL? So
Okay.
that distinction has to be made.
So if I
And
understand you correctly, if it is not a double expressor, you will not ask for the fish test. Is that correct?
so no, so if it's not a double expressor, then also you would want to do a fish. I was coming to that. So if it is a double expressor, you definitely do it. If it is not a double expressor and it's a on the IHC, you feel it's a non-GCB phenotype, I would still want to do a fish test and confirm whether it's not a double hit lymphoma.
Fair enough. Dr. Kunal, mostly the ABCs are supposed to be non-DHL. The DHLs are generally GCB. Would you agree with that, or do you think it is now really immaterial?
So I put it this way, that double expression is very common in the ABC types.
Right.
But majority of the DHLs are GCB type. So
Correct.
simply going by the GCB and ABC typing, it's very difficult. So what I'd also like to add is, whenever we say double expressor, one thing which the clinician should ask and see in the report is the percentage positivity of MYC and BCL2. For MYC, the definition is 40%, and for BCL2, it's 60%. So sometimes 50%, sorry. So sometimes when people ask for a
70,
so sometimes when people ask me for a triage that, would you do one marker? I would say if the CMYC is negative by fish, it is then not possible to do a double hit, triple hit. It's not there. So that's the strategy I would follow. But I would agree to Dr. Shruti that, even if it's whichever phenotype, you might not take a chance because it's a matter of percentages.
Dr. Shirsagar, if I can bring you in, what genetic alterations would you test for, and again, how do you test for these alterations?
So, like Dr. Shruti had said, similarly, that will be my approach for approaching these patients.
Okay.
And as per the Hans algorithm, we'll with a GCB versus non-GCB. And molecular test I haven't done for any of my patients, so I'm not very well aware of it.
Okay.
So
Fair
I'll
enough.
just be
Fair enough. Dr.
depending on
Hollis.
the fish test.
Dr. Hollis, you are in TMH, which is a education, which is a research place. So what's your approach now there? Would you do for all DLBCLs, or do you also do in some cases and don't do in some cases?
Sir, in some cases only, not in all cases.
What are those cases?
Sir, those cases, as told, is cost constraints.
Forget about the cost. You're in TMH. TMH has lots of funds to do a lot of things.
I would definitely go for all cases. I would like to do the molecular profile.
Very good. How would you order it? Would you do a fish, PCR, southern blot? It's an old technique, but remember, all the initial texts were actually done on the southern blot, and it's supposed to be good, or an NGS that Dr. Puneet was talking about.
Yeah, we'll do a fish, not for an NGS right now.
Not for an NGS right now. Dr. Kunal, what's your take on this? Not NGS right now. He wants only a fish.
So my take is, those panels are not easily available. So once they are easily available, people will slowly go towards NGS than fish. I think NGS will answer far more questions.
Okay. I think Puneet has left. I can't see him. Are you there, Dr. Puneet?
Yes.
Okay. Your take, fish versus NGS.
I would love to do an NGS, obviously, and fish obviously has limitations.
Right.
And based on what we are looking at in the future and targeted therapy, at least I would want to do it, but we have to correlate it.
Okay, Dr. Sharnagat, Dr. Vijay Sharnagat, what's your take on this? Would you want to also test for all those things which Puneet was showing us? EZH2, the so on and so forth. So many were there. Or are you satisfied with your DHL?
So see, that is not possible in our clinical practice to go ahead with like all this sort of specialized tests. But routinely, I'm going with like fish test only. Whenever I'm getting some positivity like CMYC, BCL2 or BCL6 on IHC. Otherwise, I'm not going with this type of the additional test.
So last question before we come to the case, Dr. Sehgal, what's your idea of how is the positivity of DHLs in India? How commonly do we see it?
I think from a lymph node biopsy is one of the most common tumors. I don't know the actual percentages. I see very few lymph nodes in practice now.
Okay.
But
Dr. Puneet, your experience? It's around 3 to 5% in literature. That's why I just want to know what's the percentage in India.
The high risk, the DLBC, the
I'm
DHL, right?
DHLs, yes, DHLs.
So, I mean, till now, obviously I work in a corporate, so it's obviously very rare, but somehow this side of the town, if probably we have seen 10 lymphomas, 3 or 4 have been the high risk, DEL, and
No,
probably
DHL.
they came as a...
No, I'm asking specifically DHL because see, the idea of today's meeting or today what Asha wants us to know is, are we doing a crime tomorrow that we are not testing for a DHL or a C or a fish test for all our patients? Will that patient go elsewhere and people will say, oh, what a crime has been done and you're not tested for this at all?
So
I just want to know.
So I don't do fish for every patient, so I don't have the exact.
Okay, perfect.
If it's an aggressive lymphoma on IHC,
okay. We'll come to that then. So this was a patient who is now getting treated, 48-year-old gentleman, came only with weakness and weight loss. He did have a performance status of 1, multiple neck nodes, but the largest was only 2 centimeter. FNAC done outside showed a lymphoproliferative disorder with LDH raised. So we got a PET scan done, and that PET scan showed multiple lymph nodes. And if you can see, there were nodular opacities with FDG uptake, not Corads. This was not a Corads report. In both the lungs, there were lesions in the liver, there were multiple lesions in the spleen, multiple bone lesions. So overall stage 4 disease, and this is the biopsy done. Okay, and this is again from a corporate hospital. So yes, the result, this is approximately what the IHCs are being done. So Dr. Sehgal, first off from you, satisfied with this kind of a report? Or you have done around 7-8 markers, is that enough, or would you think there's something missing?
So as the primary report, it looks complete in terms of having done the IHCs and labeling it as far as the GCB ABC subtype. But yeah, would advise what is the next step to be done, that fish analysis is advised.
You would advise a fish analysis. Very good. Coming to my panelist, Dr. Shruti, would you advise a fish analysis in this case? Remember the MIB index is 70-80%.
Yes, and like Dr. Bhausab has also mentioned in the chat box, so IPI is also something that should be considered.
IPI is 3/5. I have written there.
Yeah. Yeah.
Okay.
So here I would definitely want to do a fish test to confirm.
Why?
So yeah, so I would want to see if there is a MIC rearrangement on the fish.
Okay. So the reason I'm asking you is because, is it because of the extent of disease that you wanted? Is it because the MIB index is 70-80%, or what makes you think this could be a DHL? Remember, the CMIC is negative.
Yeah. So yeah, so all of them.
All of them. Okay. Dr. Shirsagar, what's your take? Would you advise in this case, or do you have a cutoff? So there is some data, I mean, there's some anecdotal stuff that, the MIB index should be more than 80% or 90% before you consider DHL. So 70-80% is what my pathologist gave me. Would you advise?
So I would consider doing fish test on this patient.
Okay.
Because he has an extensive disease, and so that's the main reason. And
fair enough.
IPI is also on higher side.
That's fine. Dr. Hollis, what's your take on this? In TMS, this patient lands up. Would you do for this patient with a CMIC negative on IHC?
Definitely would recommend a fish, as because there is no robust clinical or IPI criteria to go for a fish test.
No robust IPI or clinical data. All right. Supposing this was a patient.
Sorry. In patients who have CMIC positivity with more than 70%, from what I've little on the pathology side I've read, it's very highly likely to be CMIC positive even on the fish.
And what about the negative?
Patients who have CMIC negative, especially less than 40%, it's highly unlikely.
That's exactly why I was asking.
What you're asking is this.
I wouldn't have done fish. I wouldn't have done fish here.
Right. So this is just something, a poor man's fish, probably a CMIC positivity is probably something that correlates. But remember, we need to look at the percentages that has not been reported here, and quite a few of the places do not report this percentage unless you specifically ask them to. So that's again a take-home message which I would like to give to people, right? So this patient had an index of 70-80%. So Dr. Hollis, supposing this patient had a stage 2 disease. I had another case which I have not put up today. Stage 2 disease only with a nasopharyngeal mass, bilateral neck node, MIB index of 70%, and IPI of 0/5. Would you do a fish in that case? Again, DLBL.
I would still recommend fish because there is no, as I said, there is no staging criteria to recommend a fish.
So essentially, you want to do fish in everybody, if I understood you correctly.
Yes.
Okay, right. Dr. Shruti, Dr. Shirsagar, do you agree? Any patient whom you would not want to do a fish?
So I think, yeah, I would want to do it for everyone.
Everyone.
Yeah.
Okay.
You can.
Fine.
Yeah.
Okay. Very good. So this has been answered, and then which patients we ask for? Generally, the balance of opinion seems to be we should do it in everybody. So let me ask the people who want to do it in everybody. Dr. Shruti, why do you want to do it in everybody? Is this for prognostication or will you base your therapy on this?
So both for prognostication as well as I would want to escalate the therapy if it's a double expressor or a double hit lymphoma.
Okay, double expressor and a double hit. Okay.
Yes.
Dr.
So
Shirsagar?
double for double expressor, I agree that there is no currently evidence to say, but they do not do as well as the non-double expressors. So yeah. So
Dr. Sharnagat, what's your
indirectly.
take on this? Dr. Sharnagat, Vijay Sharnagat, are you
Perform
there?
fish test with maybe all the patients. Yeah, I'm there.
Okay.
Hello.
You will do it for all the patients? Very good. Why will you do it?
No. I will not be. Hello. Yeah, I will not do for all the patients. So I will consider to go ahead with the fish testing for the patients who are like strongly c-MYC positive, because the translocations routinely happens with the c-MYC. So from like BCL2 or from BCL6. So this is translocation. So if c-MYC is positive, then only I should consider patient for fish testing or further genetic testing. Yeah.
All right.
Yeah.
Dr. Hollis, TMH, what's the plan now? You do a DL, you testing, you find a DHL, do you change the therapy for DEL and DHL? What's the thing going on in TMH right now?
The option remains the same. The backbone for DL will remain RCHOP.
Okay.
There is limited data for ibrutinib. And that too, as Dr. Jain, Dr. Puneet has
What are you doing? Let's see. Data is a lot. Dr. Puneet showed us plenty of data. So we are now practicing today.
Has the screen, is it seen or? Is it...
Which one, Dr. Puneet?
No, I'm so sorry. Is the screen seen? I cannot see the screen.
The screen, others have to tell. I can see it, obviously.
Yeah, we can see.
We can see.
Okay. Right. So what is the plan of therapy for DL, Dr. Hollis? RCHOP alone?
RCHOP alone.
Dr. Shruti?
Yeah, so RCHOP is the therapy that you would want, but for a high disease, especially for a younger patient, I would want to offer an escalated therapy.
For a DEL?
Yes.
Fair enough. Dr. Sharnagat, your practice?
Yeah, for DL, so maybe I will prefer to go ahead like dose adjusted EPOS and
for a
maybe
DEL or a DHL?
That is DHL, sorry. Yeah.
DHL. Okay, that's why I wanted to know what is why doing in DL. Okay, Dr. Shirsagar, what's your practice? Do you change as therapy for a DEL?
DEL, I'll stick to RCHOP.
Okay.
And for DHL, I'll go for RDIPOP.
So if I can ask Dr. Puneet as a judge, since you have covered this topic, what's the plan Monday morning for a DEL and a DHL?
So basically, DEL, I would consider RCHOP followed by an autologous, or an intensive regimen like a in a young patient with dose adjusted epoch. That's what our epoch. That's what I would consider in a
for both DEL and DHL.
Yes.
Okay. Fine. I think this is something there is no real answer to it. DHL certainly seems to be what people are giving, but DL I have my own doubts on it. Right. So everyone talks about RDIPOC. What's our experience with the protocol? Dr. Shruti, how easy is it? How toxic is it? Do you think it's a doable thing for us in India?
It is easy to give, but it is difficult to manage. So you have to look at lot of things. Where is the patient staying? Who are the caregivers? How intelligent they are? So all those things are there. So giving is very easy, that TMH has taught us. But private practice, managing the toxicity would really, until and unless patient reaches day 21, you will be like, you'll keep having arrhythmias. So toxicity is there. Definitely you have to keep your eyes and ears open to it. And most important, I will say, for dose adjusted epoch, the IQ of the caregiver is very important. So once you are confident that the patient is in good hands, then you can go ahead, counsel, and go ahead with it. So no issues. Toxicities can be very well managed. They will have toxicities, definitely. That is the whole idea of dose adjusted epoch, but you can manage them. Am I audible? Was I audible?
Yes.
Yeah,
I think the slides have gone out.
You are audible. Yeah. I actually dropped out because of power cut. Dr. Ashay, can somebody share my screen, please? I'm actually on mobile now.
Tarun, hello.
Yeah, we'll do that.
Yeah, please
right.
do the needful.
Okay.
Yes.
So I had just asked Shruti about the toxicity and management. Dr. Hollis, TMH, how easy is it to manage DIPOC?
Sir, administration itself is an issue, especially
Right.
on the general side. Difficulty in arranging beds. Definitely, it is an easy drug to give. The logistics are difficult. Management of toxicity, logistic wise, is difficult.
Okay.
Not that difficult in terms of management per se.
Okay.
The logistics
Dr.
are
Puneet.
difficult.
Dr. Puneet, you work
Yeah.
in Apollo, so how easy is it or how difficult is it to give it there?
So we use it for a lot of DEL, and obviously, as Dr. Shruti has rightly said, you need to be very careful about the cytopenias and all that stuff. But what I also do, and let me be honest, is I don't escalate the dose after every subsequent dose adjusted. I'm sticking to the first cycle of, that itself is a toxic regimen, and I have not. That's what I've been doing.
I completely agree with you. I work in Apollo as well, and it's not easy considering all the issues with regard to the toxicity management. Giving the drug itself is one expense. Managing the toxicity is a bigger expense sometimes. All right, Tarun, this is not my slide. If you can see, it is somebody else's. So if you can bring in my slides in there. So just finishing the other topics, Dr. Srivastava, sir, if I can
now
ask
you
you
can
at this one.
which slide number you were in, sir?
I do not remember, probably 7 or 8. If you can just put it there, I'll tell you which one it was.
Yeah.
Dr. Srivastava, sir, I'm sorry I haven't included you till now. This was pretty much a core pathology discussion and other discussion till now, but I want to bring you in at this point. For a patient with a double hit lymphoma, what we have been discussing, is there any difference in terms of radiotherapy that you give to the patient?
Yeah, I think when we are talking from my period of time, there was a good role of radiotherapy in the
slide
lymphoma.
number 7.
But when we look at your time, there is a lot of decline of the radiotherapy practice as a radiotherapy use in the lymphoma. So when you look at double hit lymphoma or the triple hit lymphomas,
Yeah, just stop here, Palak. Yeah.
Yeah, and especially when we are talking of these cases, especially for the bulky disease, there is still a role. But when we talk of the smaller disease, which really is completely gone after the chemotherapy, there is hardly any role which has been shown.
So what about the patients who are receiving DIPOC? Because there is enough data now in at least PMBL and mediastinal lymphomas that if you have given a DIPOC, probably you do not need to give consolidation RT in those cases. Would you say the same for
I absolutely agree with you. The DIPOC, when we are looking at, there is hardly any role of radiotherapy, which is actually against the radiotherapy in that.
Okay. I think a lot of your radiation colleagues do not share your enthusiasm for not giving radiotherapy. But anyway, that's aside from this. This is just a slide to show the dose-adjusted REPOC compared with R-CHOP. Remember, this was across all people, all patients with DLBCL, and it was a negative trial. Next slide.
Absolutely.
Next slide. Next slide. Next slide. Okay. So final part of my discussion today, Dr. Shishsagar, what's the role of CNS prophylaxis in high-grade DHL, DEL? Would you still do it? And what's the role of auto stem cell transplant, autologous transplant?
So for CNS prophylaxis, we calculate the CNS IPI, and if the CNS IPI is high, then definitely I consider giving high-dose methotrexate in all the patients after, yes.
Okay.
And after every 2 cycles of chemotherapy. And if I'm giving RDIPOC, definitely I'll be including intrathecal methotrexate in those patients.
Okay. Dr. Shishsagar, what's your practice? Sorry, Dr. Sharnagat, what's your practice? Dr. Sharnagat, yeah, can't hear you. Okay, Dr. Shruti?
Yeah, so CNS IPI, and then some specific sites like testis, breast, kidney, adrenal, paranasal, so all those.
Nothing specially for DHL, DL, basically what I understand from you.
So no, as of now, no.
Dr. Hollis, DHL, DL, role of autologous stem cell transplant. Dr. Puneet said that he would be advising it in all cases of both these diseases. What's the present plan?
No.
Not in CR1. Not in CR1.
Not in CR1. All right. Dr. Puneet.
Yeah.
So your rejoinder not in CR1, you would still agree, or you would go with CR1? I agree, it's a controversial topic, but
this is not an easy answer. Based on retrospective studies, autologous transplant has not shown too much benefit when you have used intensive regimen. So when you're using a regimen like an R-CHOP, you should consider autologous transplant. But when you're using an induction regimen like an R-EPOC, you can take it based on the response. If he's having refractory disease, then I would probably consider either targeted therapy or even consider an allogenic transplant in situations where it is possible. That's how we do practice. That's what I've been doing till now.
Final question to all my panelists: newer drugs in routine therapy of DHL, DL, are we doing it? Or yes, no? If yes, what are we using? Dr. Puneet, starting from you.
Sorry, come again.
Routine therapy of DHL or DEL, do you use the newer drugs routinely, not in relapse refractory, in first line? Okay.
I haven't used anything.
You haven't used. Okay. Dr. Shruti?
No, not in the routine therapy.
Okay. Dr. Sharnagar, Dr. Shisagar, and then Dr. Sharnagar.
I may add lenalidomide in some cases of DHL. That's if you consider that newer drug, but otherwise no.
Otherwise no. Okay. Dr. Sharnagat? Okay. Next slide. So I think we had an interesting discussion. There is really no real hard evidence for ruling out, but one thing is that we do use these detection for finding out, especially for the BCL2, BCL6 and the c-MYC. As Dr. Sehgal pointed out, in case you have a c-MYC positive, then there's a higher chance of a DHL or a DL. c-MYC could be a poor man's technique for doing it. So we need to look at that. It's important for prognostication. Therapy can be intensified, though the hard evidence doesn't seem to be there. By and large, all panelists seem to agree that for the DHL, we would use the R-DIPOC or a R-EPOC. Not very easy to use in routine practice, but something that can be done without too much difficulty. So if there are no other comments from the audience, I thank my panel and hand over back to the organizers. I'm sorry, I think we are a couple of minutes over time.
Thank you.
Thank you, Dr. Vamshi. You're very kind. Thank you.
And thanks all panelists. Really a great discussion. I mean, Dr. Vamshi, you live beyond expectations. You don't just. So just there, we have Dr. Sameer Milinkiri sir also with us. Dr. Sameer, can you just maybe have a summary brief about it?
A summary of what, Ashay?
Yeah, so what do you do in DLBCL? Do you really use Yes, I have been your student, so now recent change in practices.
Ashay sends, suddenly he will wake up everybody, What did he ask?
No, I just said, so DLBCL now we are seeing, because the thing is,
it is too much. It's a very long discussion, so I can't go through everything. But I would just say that for the DELs, I use R-EPOC and no autologous transplant if in complete remission. DHLs, yes, autologous transplant in first CR. And was with between R-CHOP and R-EPOC for DELs. Although there is no the data suggests that there's not much of a difference. Practically, when I've discussed with national and international experts, most of them prefer R-EPOC for the DELs. That's all I could say.
Okay.
No new agents in upfront treatment.
Yeah, and Dr. Bhausab, any change in the TMH protocols recently?
No, I think we follow the same thing. So our EPOC use, in fact, has gone down recently after the negative study. It is not easy to handle. And I think one thing which I wanted to point out is sometimes you get these double hit lymphomas with low IPI. So maybe that is where one subset where we need not be aggressive. But double expressor, we don't treat differently from the DLBCL as of now. But as Dr. Sameer said, R-EPOC can be considered. Double hit, I completely agree. Probably the best way is to do lighter chemotherapy and transplant. But as Puneet said, aggressive chemotherapy is an option. So sometimes use a dose dense, intense, Burkitt-like treatment there.
Sir, as you rightly pointed out, because there can be some DHL, basically they present with low IPI or maybe at a lower stage. So do you see if you really do not give them the CNS prophylaxis, they relapse very early in CNS or anything like that? I mean, like anybody has any experience?
Data is not really clear, but there is a recommendation to give them CNS prophylaxis if this is a double hit histology, double expressor. So that's one thing. But this is very small subset of patients, so data is evolving.
Yeah.
Given their systemic burden, I think the CNS prophylaxis is recommended most of the times, otherwise also. But being specifically double hit, probably it's worth considering.
Yeah.
Bausa, when you mean CNS prophylaxis, you mean intrathecal or you mean high dose methotrexate?
High dose methotrexate, and we usually give it after completion because controlling the systemic disease is more of a
And
urgent.
how many cycles of HDMTX do you use and what dose do you use?
2 to 3 and 3 gram per meter square.
Yeah. Okay.
So usually, I mean, I think that till I was there, TMH protocol was, at least placed after cycle 3 or, one cycle after 3, after 6, if it is a well controlled, or maybe complete after 6.
But,
So thank you.
some even tend to give after completing all the cycles.
Yeah,
and
so
then
that's
that's exactly what you
said. The disease control is the most important thing, I think, systemic disease control. That's the most important, but early CNS. So, thank you for wonderful discussion.
Yeah, sorry, just to mention one point also, I think there was one paper where you have to, if at all you're using in between the R-CHOP cycles, there was a blood paper where you have to use methotrexate before the 9th or the 10th day, I think.
Yeah.
So the duration
I
of
think that's a European study which has recently come up.
that was published in Blood.
Within 10 days, so that's...
Yeah, you have to use it within 10 days of giving the R-CHOP. Otherwise, it'll cause prolonged cytopenia.
Yeah, sure. So thank you very much. We have wonderful discussion on DLBCL. Anyway, it will just go on and on. So now I invite Dr. Kandan Subramanian. Again, I am fortunate to work with almost majority of these people. So Dr. Kandan Subramanian, he is a senior consultant hematologist and bone marrow transplant physician in Pune, attached to Sahyadri Hospital and KEM Hospital. Welcome, Dr. Kandan Subramanian. He will be speaking about another, what you can say, controversial, whatever you can say, about mantle cell lymphoma, ideal approach to treat mantle cell lymphoma.
Okay, thank you, Ashay, for this opportunity to come and talk here. Am I audible?
Audible, sir. Yeah, just share the slides.
Yeah. Yeah, but there was another suggestion I was going to make. We are already running late by around half an hour. And generally, didactic presentations are boring. So can we just go ahead and do the...
So we have expert, like lot of panel of experts. So definitely you can just go ahead, sir. Yeah.
Okay. No, I was asking whether can we go ahead with the next session rather than this? And go ahead with the...
No, you can finish in 10 minutes, no issues.
Sure. Okay.
Can't escape.
Can't escape, right. So here we go. So mantle cell lymphoma, my take on this, is there a best approach in treatment for MCL? And what you come to sort of understand when you do a presentation like this is obviously the answer is no, because of...
So you need to share your screen, please.
Okay. I don't see a option for that.
So on
that baseline green option is that share screen.
Yeah.
Yes, so you can share your screen and share the panel.
Is it coming now?
Yeah, we can see your desktop. So we have the
you need to click on the presentation.
You can just click on that presentation.
Okay, but there it is.
It's open.
Yeah, is it there now?
It's opening up, sir.
Is it seen now?
No, sir. Yeah,
yes.
Now it's seen. Yeah. Yes, sir. It's seen your slides.
Okay. Okay, so going to this. So mantle cell lymphoma, to summarize, a malignant transformation of the B cell type with genetic hallmark of translocation 1114, and it has a male predominance and typically presents with advanced stage. So to start with the clinical presentation, here is a 49-year-old man who has an abdominal mass that has progressively worsened. Are you seeing?
Yes, sir, your slides are visible.
Slides are visible.
Yeah.
Okay.
So 49-year-old man, yeah, other labs.
So he has 14 kg weight loss, denies fever. The CT scan shows a mesenteric mass. And the axillary node biopsy is classical with CD5 positive, CD20 positive, CD23 negative. On the IHC, it has presence of cyclin D1 expression, which confirms the diagnosis of so just one sec.
Yes, Vivek, hello.
Yeah. So other labs are LDH of 345, which is higher than normal, beta 2 microglobulin, a normal WBC count with a hemoglobin which is on the lower side, and platelet count of 1,80,000.
Sure,
so when we think of starting a treatment for these patients, then obviously we start with simplified MIPI calculations, which includes 4 prognostic factors: age, the performance status, LDH, and leukocyte counts. And then the risk groups are well separated as low risk and intermediate risk and high risk with different prognosis. When you include the Ki-67 index, it has its independent prognostic value in mantle cell lymphoma, as we know. And you can combine the Ki-67 and MIPI score into an MIPIC score. And that again differentiates the whole lymphoma into 4 different groups of low, low intermediate, high intermediate, and high, with the low being with a median OS of 9.5 years, and the high being almost 2 years. So before we start, do all patients of mantle cell lymphoma require treatment? The answer is no. There are around 20% of the patients of mantle cell lymphoma who do not need treatment immediately as soon as diagnosis. And the predictors of the deferred therapy is lack of B symptoms, normal LDH, a leukemic non-nodal presentation, which is like CLL, a good performance, a Ki-67, which is less than 30%, and lack of blastoid variant on the histopathology. Now, if you look at the MIPI score, it has been not associated with selection of deferred therapy. That's one. And the other things that you can include in this is expression of CD200 and SOX11 expression, which should be absent, and IGVH mutation status should be mutated. So
Hello, Dr. Kandan, I think got disconnected.
Yeah, Ashish sir, I think there's some issue with the internet with sir.
Yeah, I think then we can just start as per his discussion. Yeah. So, Dr. Vivek, hello. Hello, am I audible?
Yeah, sure.
Yeah. So, Vivek, I think you can just start the next session, maybe. I think because there is some connectivity issues. So, I think you can invite our next debaters.
The debaters. Okay.
Okay. If time permits, yeah, sure.
Sure. So I did see Venkat on the list of.
He's there.
He's already logged in, and his Lingaraj is also there.
Lingaraj.
Yes, sir. I'm there. Sir.
Yeah, sure.
Okay.
So one sec. Basically just to introduce Dr. Vivek Radhakrishnan. Dr. Vivek Radhakrishnan, he's Chief of BMT Coordinator and Immuno-Oncology Department at a prestigious Tata Memorial Center in Calcutta. So he from hematology pushed me into oncology, and he himself moved from oncology to hematology. So welcome, Dr. Vivek. Welcome to moderate these sessions. Definitely, this is one of the hottest sessions of this CME.
So good evening, everybody. Thank you, Ashay, for being the nucleus of this program, and Bhav Sahib for contributing so actively throughout the program. It is a pleasure always to interact with all the panelists in this sessions that we have. So it is my honor to invite Dr. Lingaraj Naik, who is faculty at Tata Memorial Hospital, and Dr. Venkat, who is independent hematologist and director of the bone marrow transplant program at Pune. I'm sorry. Yeah. So the topic that has been decided today is essentially whether immunotherapy will replace autologous transplant in relapsed refractory diffuse large B-cell lymphoma. So we all know that the last 5 years has seen a lot of progress in this field, especially with the kind of outcomes and recent approvals of CAR T-cell therapy, starting with Yescarta in diffuse large B-cell lymphoma. So there is an ongoing debate whether immunotherapies, especially CAR T-cell therapies, are set to replace the conventional autologous transplants that we practice as standard of care in relapsed refractory diffuse large B-cell lymphoma. To speak for the motion is Dr. Lingaraj, and to speak against the motion is Dr. Venkatesh. Both are eminently trained. Both of them are subject experts in the field of lymphoma as well as transplant. So I look forward to a very active debate and rebuttals from both the sides. So first, I invite Dr. Lingaraj to speak for the motion. Over to you, Dr. Lingaraj.
Am I audible, sir?
Yes, you're audible, Lingaraj. Share your side.
Okay. Okay, so thank you, sir. And the topic given to us for the debate is, will immunotherapy replace auto transplant in relapsed refractory DLBCL? And I'm debating for the motion. So, well, it has, if you see, it has already replaced in the developed world. So this is the CABMTR data of auto transplant in DLBCL published 2019, and you can see the stark decline in the rate of auto transplant from 2017, and it all goes to the CAR T centers that has developed in the Western world, and almost it has decreased the rate of transplant by 50%. Well, so let's get to some number. All of us who practice lymphoma and transplant will be well versed with this number. So let's take 300 DLBCLs and treat them. We know that 200 is going to be cured definitely. So 100 will be relapsed refractory. So there is a heterogeneity there. There will be some patients who will be refractory, and there will be some who will just relapsed with sensitive disease. So what will happen in a real world scenario? So not all your patient is going to be a candidate of transplant because of various reasons, say poor performance status, comorbidities, organ dysfunction. So definitely 50 will be transplant ineligible. So now let's come to 50 patients who are going to be transplant eligible. Okay, so we're going to give salvage. How many will respond? 50% will respond. Okay, they'll go for transplant. So what is the long-term survival rate of transplant in chemosensitive disease of DLBCL? 40%, so 10 are going to be cured. Definitely for this 10 patient, my next colleague is going to fight, but I'm looking at the patients who are those who are going to fail after transplant, those who will not be eligible for transplant for various reasons, and that is a major unmet need. So let's say, what do you mean by relapse and refractory? I will just divide this into 4 different categories: primary progressive disease, significant residual disease at the end of treatment, Early relapsers relapsing within 12 months of treatment. Late relapser are those who are relapsing after 12 months of treatment. So that is the bit of heterogeneity when we say relapsed and refractory. Now let's see the outcomes. So what are the data that is already available to us of auto transplant in relapsed DLBCL? There are only two trials which is major, that is PARMA and CORAL. You know the design, all of us know the design of PARMA trial. It was addressed whether the transplant is beneficial than giving just chemotherapy in relapsed DLBCL. And you can see 2 cycles of DHAP randomized into transplant versus continuation of 4 more cycle of DHAP. Now coming to the CORAL study, which was not intended to for transplant, it was to check which salvage regimen is better, whether it is RICE or RDHAP. So then there was a second randomization of rituximab maintenance versus observation. Now let's see the PARMA trial. This my friend is going to allude to very well because it is one of the positive trial of PARMA trial, but caveat important too. First is it was in the pre-rituximab era, and it took all chemosensitive disease and CR was a prerequisite. Definitely there was a benefit, but what happened in CORAL, you'll be surprised. Now let's see with the CORAL study. Addition of rituximab. All patients received rituximab in the during their first treatment and they relapse. So what happened those who didn't receive rituximab? Now we see the outcome of all the patients, that was 30%. You can see the first line, it is 30% 3-year event-free survival. But when you just divide them who received rituximab or not, those who received, their outcome was better. Those who received rituximab, their 3-year event-free survival was only 20%. So there is a bit of difference when you treat these patients with or without rituximab, even in relapse setting. So now let's come to the very, very recent data that has come in Blood 2018. So this is basically a collaboration of multiple data set, CORAL, Sept, MD Anderson, 861 patients taken from various data set and the meta-analysis, and you can see the type of patient. Those who have first line relapse, first line progressor disease, second line then refractory disease, and those who have relapsed after transplant within 12 months. So basically these are the purely refractory diseases. You can see refractory to second line was 50%, early relapse post transplant is 22%. So this is a garden variety of relapse refractory disease that you're going to see. And what was the outcome? See, this is the outcome of this data, 20% EFS in 2 years. So that is similar kind of data that you see in CORAL. And what was the median OS? 6.3 months. And it is same across all kind of refractory disease. So that is kind of something which sets the benchmark for all future studies of DLBCLs, relapsed DLBCLs. So let's get the numbers right. Primary progressive disease, 15 to 20% from Scholar 1. Significant residual disease at the end of treatment, again 15 to 20% from Scholar 1. Early relapses, those who received rituximab less than 12 months from initial therapy, 20% again from CORAL data. I will say late relapses and responding, that was only subset from CORAL, which is 45%. We'll get back to these numbers again when we discuss all the options that we have in the era of immunotherapy. So now let's see what we have, right? So we have got 4 options. We have got polatuzumab, tafasitamab, CAR-T, and checkpoint inhibitors. So checkpoint inhibitors has already failed. I'm not going to put my money on this. Now, what is the biggest contender? CAR-T. Now, rest 2 are Pola-BR and tafasitamab. So let's discuss one by one. This is the data that has come up this year. This is tafasitamab is an antibody, it's a monoclonal antibody directed against CD19. So this is similarly the way it is, the rituximab is against CD20. This is against CD2. And what is the mechanism of action? This is ADCP and direct cytotoxicity. This is a single arm phase 2 study in a relapsed refractory DLBCL. Now we see the kind of patient. The median age was 72 years, not eligible for transplant, 40% refractory disease, 50% more lines of therapy. All had received anthracycline as first line therapy. What will you do to this patient in a real world? Give a single agent lenalidomide. Exactly that analysis was done in this EHA 2020. What they did was they have taken a similar set of patients who received just lenalidomide and they compared with their phase 2 data, and you see the outcome. Remember, it was 6 months. Now it has reached the lower boundary is 12 months and the median yet not reached. Now coming to the Pola-BR data. So this is a new ADC in block. Polatuzumab vedotin, it is an antibody directed against CD79B, which is conjugate to a MMAE and a chemotherapy drug. So why it was not combined with the platinum backbone? Because it has inherent property of neurotoxicity. That's why the backbone was bendamustine rituximab. Now you see the kind of patient that they have taken. Relapse refractory and the kind of responses. 50% response with Pola-BR, and the median age, the kind of patient you see, the median age is again 70 years. And what was the criteria of transplant ineligibility? Age was the most important criteria, 30%. Insufficient response to salvage, failed transplant, previous 2 or more lines. So these are the patients who are actually refractory patients who are not going to do well with your conventional therapy. And what was the primary endpoint? Response rate. But see the median overall survival. It is 12.4 months. Remember the Scholar 1 data, it is 6 months only. Right? Now the biggest contender, CAR T-cell therapy. Okay, so we have got 2 approvals and 2 major trials. I'm not going to discuss the third one, the Juma 1 and Juliet. Juma 1 is the original, the oldest one with Axicel, and the Juliet was its T-cell, right? So the kind of patient they have taken is DLBCL, PMBCL, refractory, or failure of auto transplant within 12 months. Now you see the numbers they have taken and how many they've infused. Of course, it is in a trial setting. 119 patients and 108 could be infused. Now you see the kind of disease. 80% were refractory disease and 20% prior auto. The only difference between the two was they didn't allow a bridging therapy before they give CAR-T, but Juliet allowed bridging therapy. And see the median number of median turnaround time between leukapheresis and infusion, it was only 17 days. Now you see the intention to treat analysis of overall response rates. If you see the only patients who took the infusion, it was more than 80%. But if you do the only intention to treat analysis, it is 75%. And you see the progression-free survival at 2 years, it is 38%, and you see the overall survival at 2 years, it is 50%. So again, go back and remember the Scholar 1 data, it is 20, 20, and 20. So now come to the non-relapse mortality, it is just 3%. I'll come to that in my subsequent slide about mortality. So what did we learn? So the long-term outcome data, 40% PFS, 50% OS. So what did you learn from previous data? 20%. Now let's come to something which is very interesting, is those patients who attained CR. So this is the Juma 1 update that came last year. The patients who attained CR, that is the 24 months PFS was 75% in those who responded. You can see the confirmed survival curve, they're almost going to be cured, right? So let's come to the toxicity. Of course, the toxicity is huge. The toxicities are predictable. That is most important. There is nothing which is going to be new. CRS, neurological cytopenia, opportunistic infection. Of course, they need specialized center. Most are reversible. I just want to allude. Of course, my friend is going to discuss about a lot of toxicities that you see in this slide. But I just want to allude one thing, that 54 deaths happened in 108 patients, but 50 are due to disease progression. Only 2 deaths, which is could be attributable to Axicel. So definitely the toxicity, the TRM is less. You can say, you can debate about the toxicity is huge, but the TRMs are definitely less. Financial toxicity, I'll keep it for my friend to allude. So now there is a lot of debate that these are all trial patients, they are fit patients. So these patients you don't see, and if you do this in the real world data, real world scenario, probably you're not going to get the benefit as you see in the trial setting. So what are the factors? Median age, PS, refractory disease, prior lines. So these are the factors you see in a real world patient which may not fit for the real world data. So now this slide I have taken from Karen Jacobson's slide, this year EHA. So she just nicely alluded in the Juma 1, what were the patients who actually couldn't go to CAR-T because of regions, what were the regions of ineligibility of transplant? If you see the regions, they are very logical. GFR less than 60, LVEF less than 50, inadequate marrow reserve. So now tell me which patient we are going to transplant with these characters. So obviously they are not eligible for transplant anywhere. So now come to the real world data. So this is the data that come up this year, a month back. So this is a multi-center retrospective data, 122 patients. So they have analyzed nicely the Juma 1 eligible and Juma 1 ineligible patients. And if you see the difference, it is not much. You see the difference. Overall response rate is 68 versus 70, almost similar whether the patient is eligible for Juma 1 or not. CR rate is little less, it is 40 and 63. Probably it is because of the bridging therapy these patients received, and they have definitely lesser outcome. Now you see the comparative outcome from Scholar 1, overall response is only 22%, CR of 7%. Now you just compare the data of CAR-T and the transplant. Now coming to the non-relapse mortality, that is the TRM, 6%. That is definitely high, but all the deaths were in the ineligible cohort. Of course, there are relapses post CAR-T. I definitely agree, 50% is going to relapse, but there are reasons for them to relapse. So what are the reasons? There is definitely a bit of concern that there is not much of persistence of CAR-T. There is destruction of CAR-T by the host immune system. We can do better by good selection of T cells which are going to be used again for CAR, or a balance of CD4 or CD8. And of course, they will need salvage with allo. So definitely CAR-T needs improvisation, and it is happening. This is a very, very nice Nature review paper published last year. You can see the kind of interventions being done now to improve the outcome or the results of CAR-T, be it use of CRISPR-Cas technology, be it use of CD4, CD8 differences, be used making it more humanized so that it is not getting destroyed by the host immune system, and interestingly giving checkpoint inhibitors and ibrutinib post infusion to enhance the CAR-T function. So there are a lot of things that is happening, and it is going to hit soon, and then the relapses definitely will going to be lessened as you see the newer generation of CAR-Ts. So this is allo transplant post auto failure. As you can see, all patients who relapse after auto, the options are left with allogeneic transplant in our world, and you see the data progressive survival of 40%, those who relapse after be it EBMT, CIBMT data, 40 to 50% is what we usually see is the outcome of patients who relapsed after auto. So this is a trial which has already completed recruitment, JUMA 7. It's a head-to-head comparison of Axicell versus transplant. So the results are going to be soon, and after the results, probably auto transplant is going to be out, and all patients will go for CAR-T. Those who will fail, allotransplant is the final solution. Thank you.
Thank you, Lingaraj, for beautifully summarizing all the data that is available. And one thing is sure, that Lingaraj is all set to use the CAR T cell therapies that are going to roll out in TMS probably shortly in a clinical trial. But there is also an alternative hypothesis for every topic. Am I audible?
Yes, sir.
You are audible, Vivek.
So there is always an alternative hypothesis, and what is the standard of care at the moment. I invite Dr. Venkatesh, who is Director of the Hematology and Bone Marrow Transplant Program at Kamal Nayan Bajaj Hospital in Aurangabad, not very far from Bombay, who will give us the alternative hypothesis, and then at the end we can have time for Lingaraj to have a rebuttal, and then we can conclude. Dr. Venkatesh, it's over to you.
Venkatesh, you're not audible. Hello. No, you're not audible, Venkatesh. I think you can skip here. Yeah. Hello.
His
Hello,
mic
Venkatesh sir,
connected, but
you need to
Disconnect mic.
reconnect your
Take off
earphone.
the mic. Directly on a computer audio. Network issue. Dr. Venkatesh is rejoining. Yeah. Just wait.